that's Tony with his great aunt, his aunt, who was very, very fond of. So he basically had this operation, had his mitral valve replaced, and all went well. He did have atrial fibrillation for overall about 15 years. So he worked as a crime scene manager for the Met Police, always very public minded. He was a very good crime scene manager. He worked for the terrorist team, which was actually when he became very ill. And so they worked quickly to get him in and have his op done. And he struggled. He did a week of nights every 8 weeks, and he really, really struggled with that. And he wasn't really ever quite well again. Then he had, once they discerned he was in atrial fibrillation, he went into Kingston Hospital at one point in 2006, I think, or 7, and had what's the thing you have when you have the paddles on you? You're put out for a bit of time. Someone help me out. You clinical people.
Cardioversion.
Cardioversion, yeah.
Cardioversion. Unfortunately, he arrested on the table. I was called and told that he didn't have much chance of survival, but they managed to pull him around after about 9 minutes. And I did actually distinctly feel that he had kind of a slight personality change after that, whether it was down to his fear of dying, which I think he was quite understandably absolutely terrified of. He became much more irritable, irascible, very unlike the Tony, happy-go-lucky Tony that he had been. But anyway, we carried on, we trucked on. We have, by the way, got 3 children. Sam is now 27, Lizzie is 30, and Peter is 33. So when Tony died in 2018, Sam was 24. So you can do the maths about the other ones. So basically, he then got voluntary redundancy from the Met because he'd been managing the lab at Lambeth for forensic submissions, and managed, because obviously the lab was told they had to cut back on the amount of money that was being spent on forensics. There was a massive cutback at the time, and Tony was put on the kind of gatekeeping of that, and did very well in that. But I could distinctly see that he was becoming quite unwell again. He was going quite grey, actually. I'm not just talking about his hair, it was his whole kind of facial expression. He was a very tall, slim man. He was 6'5". And he was running out of energy, and it just wasn't his age. It wasn't just his age, I felt. And then he was highly delighted because, having had 10 months of work in retirement, he then got a job working for Dignity, the funeral directors, because I'd seen a sign outside saying staff needed. And there was always that joke that they could never get him carrying a coffin because obviously he was 6'5", and most of his contemporaries were about 5'10" to 6 foot. So he did a lot of driving around in the private ambulance. And on the evening of June the 9th, I was actually in Bath with my daughter. We were going to a wedding the next day, and he was out on nights, and he collapsed when he was moving a body, and that was when St. Peter's got involved, and CCAM took him to A&E, obviously, and then thereby hangs the tale, he was admitted to your ITU department. And whatever. And I wasn't, to be honest with you, for me, because he'd already arrested about 9 years earlier, of course it was a horrendous shock, but it didn't come as that much of a shock, because I always felt, and he was on borrowed time, but in a sense I did think he might make his 70s. So he was 58 when he actually died. So I whizzed from Bath to St. Peter's. Amazing team there, really, really amazing, welcoming, so kind. His family turned up in dribs and drabs, and we had 3 days of really, as you know, sitting outside ICU, just going in to see him at intervals in various batches of people, and sitting quietly. And to get onto the organ donation part, I think and that's, as I'm clinical, I found it quite odd that it never even crossed my mind whether or not that's something because of the shock or not thinking about it. And I know there's notices up there were then in the visitors room, but I didn't even read anything. It was like a kind of, people talk about surreality and numbness, and I think I kind of had that sense, and just keeping my kids afloat. I asked very quickly. I remember asking the consultant, I do apologise because I can't remember what his name was at the time, just saying almost immediately, just tell me that Tony's not going to survive this, because I knew if Tony had been debilitated or been disabled, he would have wanted to die. End of story. There was no way he could have functioned. And I was told very clearly and very helpfully that he had a hypoxic brain injury that was not compatible with life, which was a real relief. And at that point, I think, just as a reflection, maybe it might have been an idea for somebody to just drop in to the mix about organ donation, because I would have started thinking about it then. And also because I had to kind of deal with his mum and his sister and his brothers, and I was next of kin, so that would have been quite helpful for me to kind of pave the way, really. So end of the day was, yes, of course, we'd never had a discussion about organ donation. We'd never had a discussion about him dying, because I think in a sense he couldn't face it. He knew that he was on limited time. I think underneath it all, he was quite angry about it, but we never touched on the subject. It was like we kind of wafted along. And I think I just took the decision immediately. As soon as Emma mentioned organ donation, I immediately said, oh, yes, absolutely, even though his brother and his mum was sitting next to me. I didn't even consult with them, because I just knew that that's what he would have wanted to have done, because he was very public spirited and always wanted to help people. And that kind of put a slight difficulty in my head, because I'd immediately agreed and I hadn't even let the rest of the family talk about it. I have revisited that with his brother, and he said, no, Mary, you knew him better than any of us, so that's absolutely fine by me. And so Tony went, and Emma, I can't thank you enough, because Emma was so amazing at keeping me informed about, what happened after Tony was taken off the ventilator. He died very quickly. I think, Emma, you said he died within about 5 minutes. And then the organ donation team got to work and retrieved the organs. And I know that his kidneys went to two people in their 50s. And I was talking to Emma last week and just saying, I actually would really welcome some kind of update about where they've gone and how the people have fared, even if it hasn't been a successful transplant long term. But that I'm just glad there's bits of Tony knocking around in people, hopefully, and that they're still making use of it. And yeah, that's the story. I mean, just to end the story for us, with all of us, we lived in Surrey. All three of my children and myself have moved up to Bristol, Bath area. We have moved on. I think the first 18 months was totally dreadful, and then gradually started to come out of it. And now we're kind of moving forward with our lives, which is one of those things. I mean, he's there and part of our hearts, but you have to move on. I was 59 when he died, so I'm hoping to have a few more years yet. Mind you, I'm looking at my turtleneck. And yeah. So that's my story, and I haven't asked the children to be here. I have consulted with them, and they said, no, Mum, you go and talk. But they still can't really talk about him. And I'm glad I spoke to you last week, Emma, because I did actually feel quite choked talking to you, because in a sense I've pushed it away, and it's just only now that I'm able to really talk about him without falling apart, actually. So that's the story. Oh, by the way, that picture of him with his beer and his barbecue we had a camper van, and we had 3.5 years of batting around in Dorset and having a brilliant time. So I'm glad, in a sense, I took early retirement at 55 from the NHS, used part of my lump sum to buy the camper van, and he loved it. So I felt, in a sense, he had a part of what he really, really wanted. So it would have been dreadful if he just died so soon after he'd retired and not had any kind of joy out of anything. So that's Tony. There you are. Thank you for your time and listening to me. And if anybody wants to ask me anything, please go ahead.
Thank you. I'll just say, Mary, thank you. That was amazing. Thank you. Tony's gift was able to help, as Mary said then, he saved the lives of 2 people through kidney donations. So 2 people had kidney transplants. Tony also donated his heart valves, and that could potentially, they haven't been transplanted yet, but they could potentially help a child or another adult, 2 heart valves. And he also would have helped 2 people who were blind to see again, because he donated his eye tissue as well. So actually Tony's helped, his legacy is that he helped at least 6 people, possibly more than that. And it's just truly amazing, truly amazing. And I remember, being in the room with you, Mary, and the warmth of your family, but also you were having such, the most terrible day of your life. And I don't know where you found it, but you found this inner strength within you and within your family that just, it was palpable. It really came up. And and I feel like we connected. And also, Mary was able to come along to our Tree of Life Day as well. So Mary was actually on the very last Tree of Life Day that we had at St. Peter's before the pandemic hit. Some of you may have seen our big bespoke tree on the top corridor there. And we do want to try and get that going again, because it's such an important day for families like Mary, to meet other donor families, because there's not that many of them in the UK.
That was really useful, actually, Emma. And also, just one thing to say, I forgot to mention that at the very odd age of 59, or 60, I had a tattoo done. Let me see if I can show it to you. I don't know if you can see. I had on my arm, or maybe you can see it actually. Anyway, it's a rather lovely tattoo of a fir cone, and I'd read about how fir cones they denote regeneration of life, and I felt it was just really appropriate to mark Tony's death, and I needed something on me, and it's the only one I've got, but I felt that was really important. Also, just for your Tree of Life, I felt, although there was a leaf and Tony's name was inscribed on the leaf, maybe a fir cone might be something you might want to think about or tell people, because that means regeneration of life, and I felt that was really appropriate.
That's a really lovely suggestion.
Yeah. Okay. So yeah, I'll shut up now. And also, just very lastly, Emma, when you rang me and told me about the organ harvest station, or whatever you call it, and you said, oh, they couldn't use Tony's liver, and I was like, oh really? And you said, yeah, it'd been damaged during the resus process, and I thought, oh, that's good, because he did like a beer or two, not that much. I thought, surely he didn't damage his liver that badly. So there we go. Yeah. So thanks, everybody. I'll be quiet now.
Thank you. Emma, is there anything you want to add, or Paddy, before we go for questions?
Yeah, I just wanted to say to Mary, thank you for sharing that story. It's we deal with death all the time in ICU, but we don't often get people who suddenly die in their 50s. That's always traumatic for the families and for the staff. It's very difficult, and it's interesting that it's quite painful after 3 years. So I suppose my question, Mary, is how important was the fact that Tony could donate his organs to you and the family, and has it provided some solace or some help?
It's definitely provided solace and help for the family. I think we didn't even think about it until the actual event of his death, but certainly afterwards it has provided that actually there's some part of him just still living. And I'd also like to say something about the ITU staff. I mean, my daughter particularly noticed it, that one of the nurses was in tears. She was so upset. She was brilliant looking after Tony. They all were. And I did take back after his funeral, and there were over 550 people at his funeral. And he had a guard of honour from the Met Police and from Dignity, the funeral directors. It was quite phenomenal. They shut the road. It was crazy. It was actually crazy. But I brought the funeral card into ITU so that at least staff could see the photos of him. But the staff were fantastic. And yes, everything that was put in our way as a family really, really helped us in the long term. So thank you so much for that.
Thank you.
Great. Who would like to ask Mary any questions? Danny.
There was not actually a question. It was just to say a huge thank you for coming and sharing your story with us. Thank you for your sacrifice also, because actually Tony is living on by saving the
Could I interject, please, Judith Moore?
I hope it really brings you some comfort and solace, as you said.
Thanks. Judith, you were going to say something.
Yes, I just really want to congratulate the whole episode today. I think it's wonderful to have Mary there, but also, the staff in ICU are fantastic and they work so hard. So I think it's a huge tribute to them, and thank you, Mary, for that.
Yes,
Thank
it
you,
is.
Judith.
And they were. I cannot speak more loudly for them, and I think they need to know that. And
yes,
if there's anything I can do to underline that, and also the other thing I think maybe It's just a thought, and it's probably a really difficult one to manage, and I'm sure you've all thought of it before, is how, if there's anybody that's unsure about organ donation, whether there's any way that they can speak to somebody whose relative has donated. Yeah. It's just something that maybe there needs to be a helpline, or I'd be quite happy to go on that and be available to speak to anybody who needs somebody. It's just a thought.
Mary, it's really quite on topic, that actually, because NHS Blood and Transplant has now got a volunteers manager called Miss Portell, and she is setting up a network around the whole of the UK of people who maybe have donated, someone in their family has donated, or people who with an interest, and she's certainly looking for volunteers to do promotion and things like that. And if you would want, I can talk to you afterwards and pass your details on to Katie if you would want me to.
Yeah, sure, Emma, do that. That's fine. We'll speak another time about that, but yeah, do.
Thank you.
Okay.
So we've got a number of people who'd like to say something, Mary. So we're going to start with Jane.
Thank you. Thank you again, Mary. It's a really brave of you to share such a personal story, and I'm sure it touched all of us. And you mentioned that, I was just interested in anything that we could have done better, because you said a lot of it was really good, and the team were really supportive, but you did slightly mention that you thought that maybe a conversation a little bit earlier may have been helpful around donation. Is there anything else that you feel that we could learn from, that we could take forward from this?
No, I don't really, because I think that when families are in that kind of shock and just sitting waiting outside ICU, there's not a great deal more that you guys can do, actually. That's my experience. I mean, I'm owning that as my experience. And I think the only thing is, because I've got a clinical background, and perhaps I'd already had that conversation quite early with the consultant about incompatibility with life, it might have been good for me, knowing that, to have had that conversation a bit earlier, because that was, and this is not, Emma, don't take this in any way personally, because it's the way it's probably handled when the whole family are told that the person isn't going to live, and then there's that thing where you're left to actually talk about organ donation. If I'd had a heads up beforehand, I probably would have had a discussion with the children, because they knew that Dad wasn't going to survive either, and that would have been a bit helpful, that we were more prepared for it. And then I could have prepared his family more, his mother, who's, I mean, she's elderly, but she's a nurse by background, and she's quite a strange character, and I think it would have been helpful to be able to prepare her a little bit more. So, and obviously she was losing a son, which is horrendous. So it's just maybe trying to find somebody in the family and thinking, I wonder if they could handle this discussion before we discuss it with the rest of the family, so that someone has a heads up. But it might be, it's how long's a piece of string? How difficult is that conversation? I don't know.
Absolutely.
Thank you, Mary.
It's so individual with every family, isn't it? And
absolutely.
And I do see that for you, that would have been absolutely the right thing to do. I think your understanding at the time was very quick, and you'd had several years, of knowing about Tony's hearts. Other families, they take days before we can, and we have to really listen to them. Some families, if they don't feel that they're saying goodbye yet, and there's a very subtle change in conversation from someone talking about their loved one present and in the room and in the forward tense, and then there's a very subtle change that we hear, and that's only through being silent and listening, when we hear a family start to talk about their loved one in the past tense. And that's usually an indication for us that we're at the point of asking. But sometimes if there's many different family members there, you can have that mix. So you can have some family members still talking about their loved one in the present, whereas other family members in the same room may be further along in that acceptance journey and talking in the past tense. And we can only really talk about organ donation once everybody is accepting that their loved one is not going to survive. So it can take a little bit of time. But I can absolutely acknowledge for you that would have been better to ask you, maybe one-on-one in a private room for you to prepare, obviously, Tony's mum.
And as I said, it's a very personal story, so I completely, and Emma, you've got so much experience, so I'm not in any way criticising at all. So,
No.
so yeah, okay.
Thank you so much.
Thanks, Emma. We've got time for a couple of questions before we have to finish. So I'm going to ask David and then Louise.
So it was just a very short thing, Mary. I mean, firstly to say thank you, but also comment that I think I didn't really know what to expect today, but I don't underestimate all the pain you've been through, but you've come across as so optimistic. And I suppose the question really is, do you know how rare that is, and how much you could help? I mean, you've offered to help, but I think it is absolutely amazing the way you just shine optimism after through such a dark stage. And I think it's absolutely brilliant. So thank you.
Thank you, David. I mean, don't get me wrong. There were literally days I didn't get out of bed
Yeah.
at times, and I did have to take. My work were very good. I mean, Tony died in June, and I went back to work in September, and then the following year I had another kind of slump for another couple of months when I had to go off. And now I feel I've climbed the hill, and I'm at the top again. I really miss him some days, but you know, maybe it's just personality. I'm very, very lucky. Okay, just in a nutshell, I think what I was very, very lucky for was I had an amazingly happy childhood, and I work in child protection, and I completely understand how good foundations gave me such a lot of strength. And I think that other people have not had that amazing background of childhood happiness. And I've had pockets and doors that I can open and walk into when I've had my very dark days and think about happiness. So I'm very lucky, and that's maybe where my strength comes from, is my background. And that's it, really. That was all I've got to say.
I think it's amazing, Mary.
Thank you.
And I can't think of anybody more appropriate to give the last question and comment to than Louise, actually. Louise.
Thanks, Andy. So Mary, I introduced myself before. I'm the workforce director at Ashford and St Peters. And in 2004, I was the very lucky recipient of an organ donation. I had my kidney transplant. When Emma said that you supported 6 families, you didn't support them, you completely transformed their lives. And I'm, sitting here today, 17 years after my transplant. I've got 2 children, which I wouldn't have been able to have beforehand. And in fact, my eldest daughter is named after the kidney donor. So the kidney donor very sadly died of a brain hemorrhage. She was only 32 and her name was Charlotte. So I have a 15-year-old Charlotte that is my permanent memory of her. But my additional comment was, I very sadly lost a friend a couple of months ago, and he was only 59. And he died of a brain hemorrhage. And when we were holidaying in France, a couple of years after my transplant, we were having a few drinks, and he reflected that he'd always been not anti-donation, but he didn't really understand why you would put your family through expressing a wish that when you died your organs were donated, until he met me and understood the impact that it had had on my life. So when he sadly died in May, he donated his organs. And I know that he did that, and he's gone on to, transform the lives of another 5 or 6 people. But I know he did that because I talked about my story, and I shared my experience, and I shared the kind of transformation that it had made to my life. So I suppose, 2 things. Thank you for coming and sharing your story today, but please keep sharing it, because the more that we talk about organ donation, the more people understand the impact it has. And maybe I'm quite selfish, because at some point I'm sure I'm going to need another transplant, but hopefully if we can transform the lives of many, many more people by talking about this. So thank you.
Oh, what an amazing story. I'm so sorry for your loss with your friend as well. That's really hard. But I'm so glad it's made such a difference. And thank you for telling me that. And you've nearly made me cry, but not quite. So thank you. That's a lovely thing. But I'm so sorry for the loss of your friend. Yeah.
So Mary, I'd just like to on behalf of all of us, thank you so much for coming and talking to us. I mean, I wasn't joking at the beginning when I say this is the best part of every board meeting, actually. Meeting patients and patients' relatives and our staff as well, because we really learn from these. And thank you for being so complimentary about ICU and Emma and so on. And we're really sorry that you had to go through all this, but it's wonderful that Tony, as Louisa so graphically described, you know, Tony's done the same thing for families. Yeah. And, you know, we're so grateful that you agreed to that. And just really, really want to thank you for coming on today, and also for Pradeep and Emma and Judith for joining us as well. So thank you.
Much. Okay, well, go NHS. I've been an NHS member since I was 18, and that was an awful long time ago. So keep going, lads. All right, I'll be dipping in and out of it in the next few years. So
thank you.
I'm not going yet.
Thank you, Mary.
Thank you very much.
Thank
I'm
you.
Thank you, Mary.
Yeah, thanks,
care.
Mary.
Bye-bye, Mary.
Thank you.
Amazing.
Have a great day.
Thanks, Mary.
Bye.
Bye-bye.
So that was very moving, wasn't it? It's a great. It was a great story, and thank you, Paddy, for and Emma for persisting and bringing it to the board. As you know, I was very keen that it came to the board as well. It's taken a bit of a while because of scheduling and COVID and all the rest of it, but well worthwhile. Thank you.
And thank you.
It's making it so poignant. God.
Yeah, very, very good. So Emma and Paddy, you are more than willing. This is an open board meeting. You can sit and stay, or you can go and do other stuff. Either way, we don't mind.
Okay, thank you.
All right. Right. Wow, I don't know how to follow that. I really don't. It was extraordinary, really. Been through so much and yet has done so much to help others. Great. Okay, so we'll move on now to the rest of the board meeting, and we'll start with the declaration. Any declarations of interest for anything that's on the agenda, please? No? Okay, thank you. Apologies for this meeting, I'm guessing are the Marcy Waterman and James Thomas.
And Simon.
Any other?
Simon.
Simon's dropped off now, has he? Thank you, Liz. Thanks. Okay. Just for the rest of the board members, Simon did pop in off leave to join us on closed board, so that was very good of him. And we've got welcome to Anne Carey, who's joining us to substitute for James. Welcome. Welcome, Aaron, as your first board meeting as a full non-executive director. And welcome to Chris Kane, who's joining us as an observer today, but joins us on the 1st of August as a non-executive director. So welcome. And I'll very happy to have you on board. And obviously, thanks to the departing non-executives, Keith Malkern and Neil Hayward, who did us a sterling job for 5 years. So thank you. Right, on to the minutes. And we've got the minutes of the open session on the 27th of May. So I'll take comments on those. There are 17 pages of them, so I'm not going to go through them page by page. But anybody got any comments? And then we'll just go through them. I'm not seeing any comments. No. I'm going to take those minutes as agreed. Well done. A very comprehensive set of minutes, Liz, so thank you for that. And we'll move on to the action log. First one was quality report, and that's an action for September. That consideration be given to reinstating the board walkabout, obviously within the guidelines that we've got at the time. So, Sal, is that underway? The thoughts for that?
I think Andrew and I now need to link up around how we operationalise that. But yes, I've noted that's due for September, so we'll start that work in earnest. Yes.
Okay, obviously, good. And I think it's really important with people, our staff being under such pressure at the moment, that they do see that board members are. I know the exec team are out there anyway, but that all the board members are supportive and want to understand the pressure they're under. But, okay, great. And I think the rest are either on the agenda or complete. Yeah. Okay. All right, which that takes us on then to my report. Actually, I'll take that report as read. Just to highlight a couple of things, really. I mean, Maple Ward, there's something around ward leadership because they've traditionally had a very good record on pressure ulcers, and they've now got back to 200 days free as well, and they kind of nearly always lead the way. So I was very, very pleased to go and present them with their certificates. They weren't alone, of course, but they were alone on the 200-day thing. And I just note that ward leadership has got a lot to do with this, and that particular group always seem to do particularly well. You can see, and Suzanne's report, I won't steal Suzanne's thunder, but clearly we are extremely busy, and we remain extremely busy with many challenges on many fronts. And I'll leave Suzanne to go into the detail on her report. But just to say, I remain in absolute awe of the staff who, despite all the pressure, are still performing really, really well. Very difficult times. And even though, we hope the peak of the pandemic has passed, that doesn't mean we're any less busy. In fact, there are more challenges emerging. As I said just now, thanking Neil Hayward and Keith Malkern formally in there, and welcoming Aaron and Chris. I think there were two things externally. We had a good meeting around place, kindly facilitated by Lord Andrew Mawson, with Baroness Dido Harding coming, and we met in the council chamber at Addleston. And it was quite a day out I think it was the first day out we'd had, Suzanne, myself, David and Tom, to go and meet anybody outside the hospital. So it was quite exciting, really. But we actually went through the work at place, and Jack Wagstaff was there. And I think we made our point about how important place is. And I remain absolutely convinced, with the new health and care bill going through, that we need to safeguard the work at place, because it's only at place that we can make such a real difference. Yes, provider collaboratives, acute collaboratives are important, but we mustn't downgrade the work at place, and that we've really started that work. The other external visit I had was to Egham Orbit, and this was to see the physio team, who've not long been in there actually. And what a fantastic facility. I can see why they like working there. A, it's a great facility. B, I talked to some of the patients there, and they thought it was great. But the most up-to-date equipment, of course, gym-wise, really airy studios. And I noted that they were actually doing a mix of virtual and actual face-to-face physio. So you had 2 or 3 ladies who were there in the room, but there was another couple that were actually on the other end of a laptop. And I thought it was quite innovative the way the physios were doing that. And I would commend other non-executives, if you want to go and see that. That's great, because I think we now have Riverbourne, we have Egham Orbit, and I think we're now open at Woking as well. Is that right, Tom? Yeah.
Yep.
And really good, and really, we've had patient story before, staff story before around Riverbourne, but that really cemented it in my mind. So I'm not going to say much more. You can see what's in the report. A few pictures there as well. Enjoyed my time walking around the new PAU, which is getting closer to be coming online. Big flexible space is what I took from it. Lots of room, lots of flexibility. Clearly, we've got some challenges with some of the delays of equipment, thanks to the combination of the pandemic and shortage of lorry drivers, ships stuck in the Suez Canal, and goodness knows what else. But it is progressing well. I'll stop there and I'll take any questions about anything. Stunned into silence. Okay. Right, in which case, if there are no questions on that, I'll move on. And Suzanne, you're going to present your report. Thanks.
Yeah. Thank you, Andy. And I suppose, I mean, the board is familiar with the format of this board paper, although we continue to evolve it. And it's presented in two parts, as you know. The first part builds on the really important and thorough discussions that take place in our subcommittees around each of our strategic objectives. And the second part is more of an update around some of the good work that's going on in the organisation. And what I try to do is summarise the kind of cumulative effect of what's the output of those conversations in the subcommittees. And I think it's really important that we've got the chairs of the subcommittees in the room, and we've got the executives that support and obviously lead those portfolios. So please sort of I just wanted to acknowledge that it's a build on the work that you do there. I think you may well have discerned a slight difference in the tone of this report from previous months, and that's quite intentional. I think what I've been able to say in previous board meetings, certainly since the beginning of the year, is that we've got a range of diversifying risks, but that in large part the fabulous work of Team ASPH and their ability to be adaptable and flexible and responsive has mitigated those risks. And that whilst we were aware of potential risks to the quality and safety of patient care and experience, as well as to the health and well-being of the team, we weren't necessarily seeing any direct evidence of that. And I think what is concerning to all of us, I think, is what we're now seeing is some evidence that the prolonged and burdensome demands on the team are starting to evidence themselves, both in some quarters in terms of team cohesion and ability to be resilient, alongside some of the probably what are inevitable degradations of our systems and processes, and management of some of our patient pathways. And that is certainly impacting on the experience our patients have of both accessing and receiving and the management of their care, and clearly presents a risk to the quality and safety. And I think the predominant driver around that is the continual adjustment of our operational posture, and the requirement to turn services on, turn them off, reconfigure them. Nothing has really, since the start of the pandemic, I think nothing that we've done to respond has ever been able to solidify and embed, because also always a new challenge or a new requirement has come on us, whether that be a further wave of COVID, or the requirement to recover elective care pathways, or adjustments in the patient profile presenting, or indeed the volume. So what's happening right now, I would say, is that the risks continue, probably not to diversify to the same extent, but they are intensifying without question. In terms of the quality area, I think the predominant challenges are that we are clearly in wave 3, and clearly the vaccination, I mean, and thank God for it, has largely mitigated the effects that we might otherwise be seeing. But there are incredibly high rates of community transmission at the moment. And I think that what that means for us is that despite the easing nationally of the restrictions and some of the requirements placed on citizens, we're not able to make those adjustments. So the burden of continuing to run the organisation under the very important and stringent infection prevention control measures remains. But there's an additional challenge because actually the public are starting to tire of some of that, and some of the interactions we're having with members of the public are increasingly challenging as a consequence. We've got what I'm calling the triple threat, which is something that I've coined. It's not something I've read, which is, so here we are in wave 3. We have got slowly rising, fluctuating, and possibly plateauing numbers of COVID patients, not placing a particularly huge demand on the organisation, to be fair. We are moving towards the end of the summer and into the autumn, which always comes with a challenge. We're certainly seeing high pressure on our paediatric pathways, which we've anticipated. We're seeing both RSV and lower respiratory tract infections bringing increasing numbers of patients, paediatric patients, to our door. And we are seeing what Anne will describe to you later is absolutely unprecedented levels of elective, non-elective demand, urgent emergency care, and that is not plateauing, that continues to rise. And all of that is sent against the backdrop that we've got of the very important work to recover the elective pathways of care, the diagnostics and day case activities and so on. So you can see a kind of a cauldron of heating up requirements on us. And of course, as we know, this is on the back of 18 months of absolute intense activity. People are tired, and although we're now in the summer and we're challenged, partly because we've really encouraged people to take some time off, that brings a burden in its own way, and whether or not we're able to rebalance all of that, I have concerns about. Financially, I think we've spoken about the pressures. Our underlying run rate is significantly higher than our normal baseline because we need to mobilise resources to respond to the demands that I've just outlined. There's a lack of clarity. I'm not telling you anything you don't know. This is openly debated in the media at the moment around the budget arrangements for the second half of the year. And it's clear that there is a requirement on us to recover some of the underlying run rate through efficiencies. And of course, we will do all that we can. We always want to deliver our financial commitments, but it will be a big challenge. We're not in any means a unique situation, but it's an additional pressure on us. The Surrey Safe Care programme, which in many ways is a shining light of something different and creates opportunity, is shining through, and I think people do engage with it really well. I think it is an opportunity for us to give the team a different focus, to step away from the everyday pressures, and that's the way we're going to frame it. But the challenge of training our team in parallel with the Royal Surrey team when we're working through those pressures is not to be underestimated, and we don't underestimate it, but it adds to the kind of range of activities that we need to pay attention to. Tom will be able to give you lots of detail, and I think you've heard some of that already, around the continued focus around the collaborate objective, the work around the strategy refresh. And I think really in many ways, all of the experience that I've just described only serves to demonstrate that the strategy to focus on working with citizens in communities to address the wider determinants of health and well-being really is the way of the future, and I think we only become ever increasingly committed to that approach as we do this really important work. So not a particularly optimistic overview. I hope it's a realistic position. And it's important, I think, for the board to be cited on the combination of risks and challenges. I'm not at all saying that we can't continue to respond, because it's by very nature of the organisation and the people within it that we will and do. But I think we just need to be really, really focused on the work that we're doing to support the team. I think renewed management effort and focus on that, and that's not a diminution of what's been done before. We just need to keep going, and I don't think there is really any other answer, frankly, but grateful if colleagues have got suggestions. So I'll stop there before I move on to part 2 and take any questions or comments, and please invite the chairs of the subcommittees to comment, or indeed the portfolio lead execs.
Thank you, Suzanne. Yeah, it's a tough situation, isn't it? And actually, you only have to look at the risk matrix and the KPIs and everything else that they are telling us that, aren't they? That we're under pressure. So, questions for Suzanne? Tom.
Thanks, Andy. Thanks, Suzanne. I mean, what I will do is comment on the priority assessment unit as you raised it in your report, Andy, and reference the delays, which there have been some actually, but we are now looking to take over that unit in August and move services into it from the end of August. So that at the moment looks like a locked-in timescale, which is really good. And we hope and expect will go some way to easing the operational pressure. I mean, clearly it's additional capacity that we have, and so that, as well as Surrey Safe Care, is another potentially optimistic thing that we've got to look forward to. But that's not to say that the challenges aren't going to continue unabated. The other element about that is the really important link in with the community, and the model of care that we're implementing relies heavily on the support of the community, actually, to enable us to increasingly avoid the need for admission of those patients, and to ensure that those services are available in the community to do that. So that's something we're going to be working to over time, and we're going to be incorporating the urgent treatment centre within that facility. And we had conversation yesterday, David and I, with NICSA GP Federation, about how that will work and the opportunities that there are in that for that part of the service to work more effectively into smooth patient flow. So we are pretty close to quite a key intervention actually around supporting some of those strategic objectives, and hopefully de-risking some parts of the service that we have at the moment.
Thanks, Tom. And I'm assuming we've got the staff for it.
We are in the process of working through the workforce models, and then we'll be getting on with it. We're already doing some recruitment actually around therapies to go in there, and we'll be putting the current upfront on-call teams in there and building a team from them. They currently operate as disparate teams, and we're going to be turning them into a single team for that facility, and then we'll have to work out how we staff the remaining space, which will then become escalation space for us.
Okay. Thank you. Chris.
Thanks for that, Suzanne. I've got to say, you know, really, that's probably the the grimmest report I've ever received from you. We've received from you, and you mentioned that, and really feel for you and the team. I guess the question really is, in the 5 years been here, we're around assurance and support. It almost feels a bit empty in terms of what we as non-execs can do. And I guess if we are the company, what can we do? We can't close doors. I definitely think it's right in the way they're moving with the ICS and joining up. But what I guess, what is it rather than platitudes can we physically do to get some assurance that we've got almost a plan B on top of plan A? And I know that's a really hard thing because you've probably got plan B, C, D, and E, and you're sick of it. But I guess it's just throwing it out there. What is it realistically we can do to support you?
I think you're asking two different questions, Chris. So you're asking me to give you assurance that I've got a plan B. I haven't got a plan B.
No, I'm not asking you for assurance on that because I know you have got a plan B, and I guess
I haven't even got plan B, let alone C, D, and
that
E.
is the point. I guess as a board, we do.
I think the plan we're doing, I think the plan we've got's the right plan, and I think that would be to know the non-executives and the board support the plans, which I don't believe for any second you don't, and to challenge us on the strategy and to ensure that we do exploit those opportunities fully, and I think do whatever you can do, which is limited. I think you're right. We are kind of saying, do you know what, the tank is getting a bit empty, and no surprise really. But whatever you can do to reinforce, for example, what a fantastic story that we've heard this morning. Share that feedback with the team. Do you have to go through us? Tell them that you heard a great story and that you're so proud of the work that they're doing. I think continual reinforcement that they're doing a brilliant job, and despite all the challenges and some of the things that haven't worked, that's inevitable, isn't it? Tell them they're going to. I think so. That would be my advice, but the execs might have other thoughts around that. And Tom, thank you for making the point about the Urgent Emergency Care Centre and the work you're doing there with David and Louise and Andrew and others, because I think it is a really important opportunity for us in terms of taking as much of that opportunity as we can to address the issues that we've got. Yeah. I don't know if that answers your question, Chris, because I think it's a tricky one. And
doesn't it? I mean, I was on the quality committee, and yes, we were looking at in terms of risk, but it seems to underpin that actually there's more risk, if you like, than we're actually even giving it credit at the moment. To say yes, there's things happening around quality of safety and patient experience, etc. Actually, it's probably worse, isn't it? And it makes me reflect again on what we should do in a quality committee and maybe in other committees as well. Especially sitting on the IDC. So grateful for what everyone's done, but we have to do it in digital, but it's still putting more pressure on everyone, isn't it?
I mean, I think we're moving from a position in many ways of seeking and knowing that we absolutely eradicate the quality risks to a position where that's not going to, if the pressures continue, that will become increasingly difficult to do. And we've shown you examples this month, haven't we, through the committee approach of where we haven't been able to fully mitigate those risks. Largely it's in patient experience, and so people get incoherent communication from us, or they don't get any communication, or it's largely in that arena. But there are some examples of, I mean, I think Andrea pointed earlier around the community pressure ulcers. We're seeing this that will be around demands and pressures on the system. That's predominantly where that is, or the medication errors that we talked about, and increasing numbers and things like that. So, the risk for patients in terms of quality and safety is definitely materialising. And I would say it's not homogenous. It's not happening everywhere all of the time, but we're seeing it happen in maybe in a way that we probably haven't seen before. And I think it's important that the board, and I mean, this is a public board, so it's quite an admission for us to put out there. But I think, you know, in the spirit of openness and transparency, that is just the reality. And so I think it's useful for us to explore it in this way together.
Yes, thank you.
And I do think that in terms of support, that we link it to that open action, which is around walkarounds as well. So I'm really keen that we can get those going again, because visibility and support and just the odd words, not being intrusive, but, you know, words of support and things do mean a lot. So I think we, you know, obviously we have to be mindful of IPC, but we also need to look after our people. So so I've got a load of people who want to speak. Merrick, start with you.
Yes. Thank you. It's two observations. The first one is that I think, as we see in the press, most of the press is talking about the backlog, and very little of the press is really reflecting on hospitals being full because of the non-COVID work being doing. And that links on to, I think, the second thing, which is, I think the remarkable achievement of the executive and all the staff in terms of, in that changing environment, which Suzanne, you know, you articulated, every minute there's a change, the sheer volume of work that is now going through. You know, we're talking about the risks as we look forward, and absolutely we are all clearly worried about that. But I think it's worth stepping back and just saying the enormous success that's being achieved in the volume and working through a backlog. And yes, of course, we've in-sourced work, and yes, we've brought in additional theatres, but actually it's down to the people delivering that.
Yeah.
And it sits on the back of some decisions taken perhaps for other reasons before COVID in Ashford, and getting Ashford set up as what we now are looking at as a clean site, but what we were looking at as a non-winter affected site. So I think despite the challenges in this really quite unique report of yours, I do think we should take time to stand back and say what a wonderful achievement that is going on despite all those pressures. And of course that brings its risk, because what we can't do is say, well, we're going to take less volume to ensure the quality. It's not within our gift to do that. So that's all I want to say.
Yeah, no, as I think you make a really important point, Merrick, so thank you.
Andrea.
Oh, thank you, Andy. It was just to I suppose just to highlight or expand a bit on one of Suzanne's points about the staff and how they're feeling. And I think from my perspective, I've, you know, definitely over the last few weeks, there's been a clear change in the complexity of patients that we're seeing, those that are presenting with a physical need, but clearly there's also the mental health aspect around that, and that's been generated from the lockdown, and that's proving really challenging for the staff. In particular areas that we're seeing that is in maternity, but also in paediatrics as well. And yeah, I think that's probably only going to get worse, if I'm being brutally honest. We're probably on the start of seeing more of these sort of complex cases actually as a result of that. And then just tied in with it is the staffing piece, really, that certainly I think with the relaxation now of the restrictions and people being able to go about pretty much what they want to do, the staff impact has been felt a little bit more now, I think, in the last few weeks from staff sickness. But the test and trace app, and people getting pinged with that, and thankfully now we've got a process in place. But for initial bit before that came in, that was causing us quite a bit of stress as well. And it was just really just to highlight those particular stresses, I think, that are contributing really to the impact on the wards. I would just add, though, just going back to the Ned walk around, that Jane and I have been doing the walk arounds as the maternity safety champion, and we did one last week, and we go around and doing a tea trolley push to get staff to talk about, you know, any safety issues they've got and they feel safe to be able to. Last week it was all about, it was a morale boosting visit, basically. I mean, you know, they were just so grateful to see us, but not wanting to talk about safety, but purely just wanting to talk about, oh my goodness, you know, the what they're seeing, and and actually how tired they are, and we're delighted with the cake and the tea. So it was really worthwhile. I think it was really. I came away thinking that, oh my God, we've done some good there, because it was really morale boosting. Bless for them.
I'd agree with Andrew. It was just so good to feel that you could do some supporting, because it's just tough out there, isn't it? So I think absolutely right, Andrew. I think if nothing else, we showed that we cared. And that's, you know, sometimes all you can do.
Really important, really important. Thank you, Jane and Andrea.
Thank you. Aaron, and then Andrew.
Thanks, Andy. My question is quite a specific one, actually. I just read in the report that one of the constraints for the outpatient backlog was clinic capacity. So I was just wondering if virtual channels were being used for clinically appropriate consults, so outpatient follow-ups, as I'd imagine that would alleviate some of that constraint, and was probably used in the heat of the pandemic earlier last year.
I think the straightforward answer to your question, Aaron, is yes. Clearly, we don't want to go back completely to traditional ways, and I can see David wants to comment, so I'll bring him in. But in my view, would be we do have to maintain it in an appropriate way. And there's been a lot of discussion. In fact, when I was meeting with our local MP, he wanted assurance that we understood the extent to which the means we use influences the outcome, and patients, you know, so enabling patients to use other means effectively is really important part of that, of actually deploying those means. So I think it probably needs a bit more work than we maybe did it at speed at the beginning. But yeah, I mean, absolutely, we're not moving back to a sort of everybody come to the hospital and do an old-fashioned outpatient appointment. David?
Well, I mean, I think you answered. I mean, the short answer is yes, but actually, as you said, there's much more finesse, and some of the increased capacity that we're bringing in is from a virtual perspective. But the thing that we learned from the first wave, particularly for new patients, you're right about follow-ups and follow-up tests are very able to be supported by that if the patients are supported by that. But new patients, what that did drive, it drove investigations. And there is a big waiting list or backlog in terms of investigations that you might exacerbate if we don't get that first contact right. So it is something that we're looking at, and certainly if you look at the virtual appointments, they're still much higher than they've ever been in this time. But it isn't the answer for everyone, as Ben Spencer pointed out, and he's right for some aspects.
Thanks.
Thank you, David.
Thanks, David. Andrew.
Yeah, just as I listen this morning, I mean, these are fantastic sort of honest stories about dealing with things in a very difficult situation, which the general public, I'm sure, absolutely understand, but they might not fully understand the detail of what it feels like to be in the middle of that, either Suzanne's story here or the story we've heard from Mary early on, with all which people would have a lot of empathy for the complications of the family, the mother, all of that stuff, which is pretty amazing stories. I was just, and actually many of us are rather tired, if I'm honest, certainly I am, of listening to some of the rhetoric and some of the narrative of our media, which never come to terms with the realities of what is actually going on in the round 360 degrees, which is what is coming through here. I was just wondering about the communication piece, really, because it is stories that enable health and communities and things to really join up. And these stories this morning, and we've had others from midwives, haven't we, and others, communicate all the complexity and humanness of all of that. And it just occurs to me, Suzanne, as we start to think about the development in Staines and in Addleston, as the different elements start to come together, and with modern technology, of course, you can do this with television screens, these stories need to sort of be shared, maybe edited and brought together in a way that human beings can get hold of, but it's maybe not now, but to wonder about that, so that actually the general public and patients and ordinary people in Addleston, Weybridge, Staines, or wherever it is,
can begin to understand what is it like to run a hospital and to be the staff in the middle of it, and as well as staff to hear all of that.
Yeah.
You know, and also the story of Mary. What is it like to be in the middle of it? And I was listening to that because a friend of mine has just lost his daughter at 20 who's been through 3 transplants. So for us, it's become sort of very, very real when you've known someone for a long time. You think, oh my goodness. And yet his daughter had sort of lived actually maybe 60 years in 20 years and had gotten OBE from the Queen for campaigning on. I mean, it's sort of amazing stories. I only just share it with you because I think there is a communication opportunity in all of that joins the dots and makes the story more human in all its honesty and openness and the difficulty of making these things work. Because that might also help staff actually feel more of a bigger thing, you know.
Yeah,
I don't know.
I
It's
think
a thought
I'm
for you
sure.
to think about.
No, I think I'm sure you're right, Andrew. I mean, I think, you know, we've seen, you know, if you use television examples, you know, things like hospital, and I think there's currently one around the ambulance service and things like that. And actually, there was a great deal of anxiety in the NHS that you would expose a lot of the challenges to the public, but actually the public absolutely love it, don't they? They love it, and also, as you rightly say, it gives the teams that deliver that care and work in those scenarios a great sense of pride and well-being, I think, because what they feel is warmth from the public and empathy for the challenges. So yeah, I think you make a really good point. I mean, I'll talk to the comms team. Our local media, I mean, we put out a lot of good stories and invite them to come and hear a good, you know, some of our more interesting, complex stories. Of course, then inevitably they're only interested in the bad stories. That's a general point. I mean, they picked up on our COVID star, and James did a great piece with Harry the sculptor on the BBC, I think it was last week. So, you know, that's a good story out there. But yeah, I'm sure you're right. We can do more, and actually more collaborative stories. So, you know, maybe positioning it in Addlestone or Staines and then doing it together with the team there in a way that talks to members of the community around it. Yeah, helpful advice, I think.
Tom?
It's just thoughts on the back of that, and it's a really helpful comment, Andrew, is that we want to include conversation with the public in our strategy refresh process, and clearly our strategy refresh is kind of one part, a major part of our response to all of this, and the assessment of our BAF and risk appetite and all the rest of it is another part that's very, very closely related, and clearly the whole board will be part of that process, and it may well be that the conversation that you're describing, Andrew, with the public is part of the process whereby we engage the public in our strategy refresh. So I think that's an opportunity we should probably not miss, and I'm happy to work with colleagues around that.
Yeah, thanks, Tom.
Good. Okay, Suzanne, I think we've come to the end of the sort of questions on that.
Yeah. So just briefly then to cover off the second part of the report, which is, you know, more upbeat generally. Just make a couple of points really. Obviously can't pass today without talking about the fire, the incident at Ashford. So we had a small fire breakout in one of the theatres in the early hours of Tuesday the 13th of July. I mean, all I'm going to say about that is that the team responded very quickly and efficiently. It was identified, obviously the fire and rescue service were in attendance. It was dealt with rapidly. All the escalations happened, and obviously there's a full and thorough investigation underway. In terms of implications, one theatre is out of action for probably a few months, but all the other theatres actually were up and running the same day after Andrew and David approved that the infection prevention control sort of cleansing, obviously that there was smoke damage and so on, had been completed to their satisfaction, and so actually there's been minimal disruption, and I'm sure Anne will talk through some of the work they're doing to sort of reschedule around that. So but it's important that the board are aware, and obviously the outcome of the investigation will be seen at board through the appropriate committee. I just wanted to put, so the surgical site infection work, and I know that the board's aware of this, and largely in part to David's dogged determination. And I suppose the reason I put it in the report this time was actually what's so good to see is that the organisation is now you know, David doesn't have to keep being the lone voice in the woods. We've got other people talking about it, and that there's more of an open engagement and conversation, which is fantastic to see, because that means that there's now a sort of an acknowledgement and a recognition that work is so important. So that's the reason for putting it in this report, because it's taking hold in the organisation, and it's only when we start to implement these things at scale that you'll see the difference really happening for patients. National Thank You Day happened, so you know that was there. And I've referenced the COVID Star Medal and the yearbook that is coming to fruition, which Louise and her team, supported by many members of the team, and I know we're all thrilled with the medal, but I think the yearbook is also fantastic, actually, and I'm looking forward to the celebrations with the team as we're able to distribute those and say thank you to our guys with something really special. And other than that, I was going to talk to the amazing simulation facilities that have recently opened in the postgrad. David and I and Andy went down and supported some educational awards for the teams that deliver education and have that continue to do so through this difficult time. And I think you can see in the report there an amazing image of one of our resuscitation dolls set within this sort of real life. And you can see it's something that you've got to go and see it. So when you come next in the hospital, go and see it. It is unbelievably amazing, this immersive simulation. And on the kind of aligned with that, the last thing I'm going to talk about is the absolutely inspirational meeting that a number of the execs had with the Bourne Education Trust. The chief executive and his strategy director came, and they literally spent an afternoon with us and Jack Wagstaff. And I mean, you know, of course, Andrew would know this. We had a huge amount in common, a great sense of camaraderie actually between us, and kind of, you know, a wow moment. Oh my goodness, why haven't we had this conversation 10 years ago? But it was really inspiring, and I think they were as inspired as we were, and they left and they sent us all a message saying, God, we were so excited with the work we can do together, to use our collective resources. And this is they're a big organization. They run 23 schools across Hampshire and Surrey, to use that collective resource, inspiration, motivation to both create work to support at the education agenda in the curriculum, to support young people as they develop their skills around health and well-being, to think about careers in the health and care sector, but in fact support their career aspirations wherever they want to go. And I link it back to the Sims suite, because we showed the team from the Bourne Education Trust the Sims suite. They were blown away, and they said, God, well, the kids would absolutely love this, which then led to another conversation about, well, why don't we use it to lean into the curriculum, use some of our clinicians, and then there's an added possibility maybe to have families in the trust while the kids are having some education and fun. You know, maybe you're able to offer support into families that are vulnerable or need extra advice, guidance, whatever it is. So it was a real. So I'm hoping to end my report on an up. I'll leave it there. Thank you.
Great. Thanks, Suzanne. And just to say, that simulation suite, I really would urge people to go and see it. It is so lifelike. It's unbelievable. They very similar to the one that's in Surrey University that the nurses use, but actually we've got more scenarios and got fantastic. And you can make your own scenario as well, which is great.
I'm not quite sure why we need to practice resuscitation on the seabed, but you know, willing to enter into the spirit of it, or indeed on the moon. but I think it creates a bit of fun, and I think, you know, on the back of the first part of the report, just to give some sense that we are still looking for and creating opportunities for the team to have some fun, which they clearly were when we went to visit them, weren't we? They were proud of it and having fun.
Yeah. Andrew.
Yeah, just final thought on that. It's really good that that's gone really well, Suzanne, and that's really very good. And fortunately, you were able to take part in the Science Summer School we've just run in Skelmersdale with Professor Brian Cox and Major Tim Peakes and Lord Winston, of course, the great doctor, which was an amazing thing in a very challenging community. And it was great to have Tamily there from Brooklands, because we're now going to do it in Brooklands, and I know you and David are going to be part of all of this. But it'd be really exciting to join the dots around all that, because Brian really gets this. Yeah. And that'd be great. And I don't know
They've
whether the
already met
suite.
Tamily. So they've
Oh,
met
great.
Tamily. Yeah. So when I raised it with them and said, oh, this is exciting. They said, oh, yeah, we've met Tamily and we really want to be a part of it. Yeah.
Great, and I don't know whether that's sweet. I haven't seen it, but so to involve some of that practicality in the whole event we put on with Tamily, to link. Brian really gets this. He doesn't want science in a box. He thinks the sciences need to connect together across disciplines, because the innovation comes from the connections, you know. And so working and joining the dots around all of that and what you're doing would be really interested. And David, getting one or two inspirational medics who can talk passionately about the science of all of that would be a really exciting thing. But not to go on about it now, but I can just see if you join the dots around that over the next year or so, it could become really interesting. Yeah.
Yeah, no, thank you for that, Andrew.
Okay, right, I'm mindful of time, we're gonna have to move us on now, unless there are any urgent questions on part 2 for Suzanne. You've still got your hand up, Andrew.
Oh, sorry. How do you do that?
Okay, so let's move on to the quality piece then. Before we hit the quality report, Jane, do you want to give us your perspective on it from a committee point of view?
Yes, thank you. I would just say that I think that the summary that Suzanne had in her report really does reflect our main areas of concern and discussion. So I won't labour that, but definitely the areas that have been highlighted, Suzanne, thank you, are certainly the areas we were concerned about. We were assured that that there was openness in reporting, and that there were clear plans to address the issues that were raised. So we were assured about that at the committee. I think one of the things I would like a focus on is actually it's tough at the moment for everyone, and I think when something goes wrong, most people in healthcare, that's not, you know, they come in to help, and they come in to support, and they come in to heal. And when something goes wrong on their watch, or they feel that they're at fault, it is devastating. And I think it is about focusing on that learning and support, so that we do have that open culture is so important. So I think that's something that, you know, we're keen to encourage through the committee. We recognise that when systems are under pressure, you are more likely to have errors, you are more likely to have, and what we need to do is support people around that, because the majority of the time people get it right. And we do get it right, and we need to keep holding on to that, and we need to learn from where we get it right as well as where we don't. So I think it's just to say that the committee had an open and frank discussion about the areas of concern, and we were assured around actions being taken, and I'll let Andrea take you through the detail. Thank you.
Okay, thanks, Jane.
Thank you.
And Andrea, do you want to just give us the highlights? You can take it as read, obviously.
Yeah, okay, thanks. Thanks, Andy. So you'll see from the report now, we've moved the patient experience bit to the front of the report. We felt that was really important to do that. It's always been at the back of the report, but actually considering it's part of our trust strategy and the golden thread through that, it should really come before everything else. So the only bit I draw out about the patient experience, I mean, we've talked a lot about it actually in the previous discussions. So, you know, themes that are coming out is you can clearly see tired staff. There's attitude of staff coming into play that patients are complaining about. Referrals with appointments, but we're going to talk about that later on in the performance report. So won't, because there's a lot of good work going on around that. And then the responsiveness on our complaints as well. And clinicians are very busy and have been busy with a reduced workforce and stuff, but we've got work in play to address that. The good news is that in the last board, I did report that, you know, one of the key complaints really particularly from relatives was about updates on their loved ones, because we had very restricted visiting in place. And there's lots of frustration around that, not really being able to get timely updates about the loved ones. Well, we've now since then slightly relaxed our visiting for relatives to come in at least 3 times a week to visit their loved one, and when they come in, they're getting an update now with clinicians. So we have seen a drop off, a reduction in those types of complaints from staff, and we're keeping that open, that relaxation on visiting. We're keeping that currently in place, but obviously we're watching it very clearly with what's going on within the community and the transmission with COVID. The other bit just to draw out is about medication safety, because we've been doing really well with our medication safety improvement work, and we have seen an increase in this report. Again, I think it's illustrative of the demands being shown. One that I'd just like to bring out was around gentamicin, and we did do a bit on Aspire to reaffirm about gentamicin, and the mistakes that have been made was patients that were given a double dose of, patients were having a dose of gentamicin. There's a couple of incidents around this, gentamicin on the ward, and then going into theatre, and the theatre staff not realising that gentamicin had been given on the ward and then giving it in theatre. And it was down to the fact of the drug cardex, the prescription sheet not being available. Now Surrey Safe Care is going to address this issue, so that's good news. But actually, immediate actions that have been put in place around this is for the ward staff not to give gentamicin, but for the theatre staff to give it as a stat dose when the patient goes into theatre to minimise that mistake happening again. So lots of good work continues around the medication safety piece to make sure we continue our good work with that. And then the other bit really I'd like to highlight is around infections. You know, we're in the top. The CQC shared some data with us actually that they get around our infections, and we're doing really well actually. I know we've set some really stretched targets for ourselves as an organisation, but actually compared to nationally to other trusts, we're in the top quarter for performance on that. So it was a really good news story which we're sharing with the teams, because you know we've got a really strict IPC strategy in place. And we've got to maintain that as we go forward. It's good to report we've had no COVID hospital-acquired infections in the last during May and June when we're reporting against this, or no outbreaks either. But I state a bit of caution around that, because there are cases that are being that are coming up now within trusts within our region of hospital-acquired COVID, and also outbreaks as well, which is quite alarming. So hence why we've got to be, you know, and we keep saying this to staff, really being extra vigilant and keeping a close eye on this. The key thing for us really, I think, one of the mitigation measures around this is about our screening of our patients. And we've got quite a good robust screening process in place on admission, and then 48 hours after admission as well. And for our elective patients, it's every day actually, so we've got to keep that robust screening in place. Around safety, just two bits to highlight. I mean, it's great about the pressure damage stuff that's going on, Andy, and you highlighted that about Maple Ward. Maple is an exemplar ward actually. I would reiterate your comments around the leadership on that. But we've had 4 wards now achieve the 100 days where they're free of pressure damage, and so that's really good to see, because we haven't seen that for a while. So there's some good work around that. And then the falls, we have seen a slight increase in falls. You probably picked that up in the report. We were doing quite well against that. Actually, interestingly enough, there's some learning from this that we moved our stroke ward to Aspen ward, and we then saw a series of falls following that actually, which resulted in some modifications having to be made to that ward environment. So we've gone back to what the quality safety impact assessment that was done before that ward move happened, and obviously learning from that if there is another ward move to make sure that all the modifications and mitigations are in place before such a move takes place. And the last point is about Ockenden. And just to mention, obviously, I'm as duty bound with the Ockenden, just to say how we're doing against the immediate actions around that. And we're making good progress, doing lots around the personal care planning, and risk assessment for our women that are coming in who are pregnant, and our recruitment against midwives. We've done great work against that, and come October we'll be fully established. And then the continuity of carer journey. Again, we've got a big focus against our BAME population with that, and that's where we're focusing our efforts. But there was a Health Select Committee report recently came out, which sort of actually just does put a bit of a challenge into the national team around continuity of carer, whether or not it was appropriate to set targets around this when the resources hadn't been put in place. So we're just waiting for some more information to come out around that, but we're still obviously working towards our current targets as they are. And the last point is we did submit our CNST compliance on the 22nd of July, following our extraordinary board approval on the 2nd of July around that. So I'll leave it there, I think, Andy. Happy to take any questions.
Okay, thank you. Jane?
Just thank you. I just wanted to add a little bit to Andrea's update on the maternity side, just to say that we do continue with our monthly safety meetings, and at the meeting yesterday, our obstetric safety champion had very helpfully looked at a CQC inspection and done a gap analysis to see where we were in case obviously we are inspected, so that we can focus on areas for improvement. And that was really helpful, Andrea, wasn't it? It really helped us to highlight where we might want to focus our activity, obviously in line with the Occotem requirements, but we're also in line with general safety. And so I think it's really good. And we also have our neonatal safety champion is retiring, and we've immediately got a new one who's very enthusiastic, has joined as a consultant recently. So that's really pleasing. So I think we have a big focus now on safety within the maternity division. And I think certainly the culture in the team is moving in the right way, I would say. And certainly Gemma, the head of midwifery, is now having regular staff safety meetings as well, which really helps them to raise any issues. And I'm made aware of any of those.
Thank you, Jane. That's very helpful. Any other questions on anything in the quality report? I've got one for you, Andrea, which sort of jumped out at me, was the decontamination piece in 3.8. It sounds like we've suddenly found something that's been going on for a while. Is that right? Because obviously these probes are very important and could be carrying infection. So is that a big issue that we've uncovered there, or is it something relatively minor?
No, it's not a big issue, and Amanda, who's our IPC nurse consultant, did speak to me about this. It's no, it's not. They're addressing it. It's not a huge issue. You're quite right. You'd think, yeah, potentially it would be, but it's not. The team are on it around that. We can do a further update on that, Andy, if in the next report.
Yeah, I was just interested, as to, is this a long-running thing and that we've just found for some, or is it something because something changed? That's all. That's all. I'm sure Quality Committee can look at it.
Yeah.
Okay. Anything else for Andrea on this report? Okay. All right. Thanks. Let's move on. Jane, anything on the minutes you want to bring to our attention?
No, just to say we accepted them as an accurate record, and it's really nice to have the divisions back in, although I do recognise they're probably under a lot of pressure, but having them at the committee does add a lot of depth in the discussions. They engage very well, and we have changed the report so that we can focus on the quality priorities when they present, so that's really valuable.
Okay, thank you.
Andy, sorry, can I just come in just to add about the IPC board assurance framework? Obviously, we just to highlight that we do cover that off in the Quality of Care Committee, and actually just the actual board assurance framework has changed since our last trust board, again from a revision from the national team. So we've gone through that. We've still got good compliance, and I think it's testament again to our IPC strategy that we have in place. So that's really encouraging. The only bit that we're really focusing on is around decontamination of patient equipment, because in some places that's not been as robust as it could be. But we've got daily environmental audits being carried out, and also a book that's documenting and monitoring the cleaning of such equipment as well, to make sure we've got really robust and auditable processes with that.
When you say patient equipment, what do you mean, Andrea?
So it's the bits that so BP machines that move from patient to patient. That's a key one that is just reminding staff to, from one patient to the other, you must clean it down.
Right. No, I thought you were talking about their mobile phones or something, their own equipment.
Okay.
Right. Although probably mobile phones are a source of infection.
It's a good point, actually. Yes. Yeah.
Thinking okay. Thanks very much, Andrea. So, learning from mortality reviews, our quarterly report. David?
Okay, well, this report's already been presented at the Quality Committee, and I suppose that the mortality appears in lots of sections in this board meeting. So there's a section in the Quality Report which covers a slightly different area, a more recent area up to July in that report. And Suzanne mentioned some of the points in her report as well. I suppose the first thing to do is, particularly looking at the quality report on what's happened to mortality, it does tell a story. It tells a story of COVID over the year and the great burden that's had on the community and patients in terms of mortality. But reassuringly, as you can see, is the numbers related to deaths in COVID has now gone to zero, and overall the mortality is lower than it's been for quite some time. And also, if you look at the risk-adjusted metrics, the SHME and the RAMI, those have always remained in the beneficial below 100. So 93.1, I think it is, averaged over the last 6 months. So that's good work, but it does tell a story on how much has gone on. I think in terms of the learning to death, there's a few things just to talk about process. So if you look at the initial reviews that go on, in quarter four, so that's January, February, March, 61% of those have been completed. Now, what you see in the quality report is the new standard is those that have to be completed or should be completed within 48 hours, and that's a really good aspiration to have, because it means that the review is done on the ward or very soon by the teams doing the initial review on that process. And in the quality report, you can see that we're now recording that metric to drive that. The other point is that of the ones who went forward to subject judgment reviews, 27% of those have been performed. And as you know, we've struggled with that, and particularly during COVID, we struggled with keeping up in those in a timely way. There is always a lag to doing those because they take quite a bit more time. But as Suzanne mentioned, Tech approved a business case which was to put some very good management support out of the medical examiners team, and also to make some available some clinician time to actually get these reports done. So I'm very hopeful that is going to start showing a very big improvement. The other area to look at is learning disabilities, learning difficulties, and as you can see, 74% of those were completed in the 1920. In fact, in quarter four, we did have 8, of which 4 have had their subject judgment review performed, and 1 did highlight there was some problems with care. But further in the report, you can see that it was examined quite fully, and actually the feeling was that the care was good. It's quite a good detailed report in there. I think the other thing that it pulls out in the report, it does identify where the learning happens, which I think is really good. So there's a triangulation piece. So this mortality review, subject judgment review, is only one part of the bit where we look at mortality, and it is triangulated with coroners' cases, SIs, and all the other information that we get. And it's disseminated through the quality and safety half days to the morbidity and mortality meetings that are now set up within the divisions, and the mortality review committee, which is chaired by the Chief of Patient Safety, Paul Murray, oversees those processes as well. And I think the other bit, just to finish on, I think in the last paragraph in the report, you can see the medical examiner impact, which I think is quite extraordinary, actually. So you can see that as they've gained confidence in their processes, you can see that I think it's 98% of cases are reviewed by the medical examiner, and they are a really good contact point for the families. They make contact with lots of the families about this to talk through things, and that's a really fantastic improvement in what we're doing. And they're helping with the other really important thing, which is to be able to deliver the death certification within a timely way. So 72-hour target around those. So I think there is. I mean, I think the report says there's some really good work that's been gone on, but there is some more support needed, which we've now identified the resource for that, and actually there's some clear areas where we need to continue improving. I think that's it, really.
Thank you, David. That's very comprehensive. Any questions for David, or indeed any comments coming out of the Quality Committee, Jane?
No, I think, David, thank you. I think the issue we had is really being assured that was some resource going in to make sure that the structured reviews were done in a more timely way, and that's now obviously been taken forward because we've recognised that for a little while. It's been a bit of a challenge for the team because they haven't had the resources really to do that. And just to support David in his that we're really pleased to see the excellent work of the Medical Examiner's Office. And I think particularly, as we've spoken before, at a time where families have maybe not been able to fully visit and understand that patient's journey when they sadly die, I think the role of the medical examiner is so fundamental in that, really, in supporting families.
Yeah, they certainly seem to have really be motoring now, don't they? They're very much on top of things. Okay, anything else on this particular report for David? Okay, thank you, David. It's a good report, actually, really helpful. Right, so we now move on to the patient experience report. And this has obviously also come through Quality Committee. So, Andrea, do you want to lead us through that?
Yeah, I will. I'll obviously take it as read and just pull out some particular points. I think it's testament actually to the patient experience team. You know, last year was a really tricky year, and you know, for that team, I think it's really important to put the context in that they didn't have a head of patient experience for 6 months, and they actually didn't have a deputy. A deputy was only put in place in January, really, of this year. So you know, for the work that they've done and the amount of work they've had to do over that time, I think is incredible and testament to them. I think just bringing out the key points, we did see a 31% increase in PALS during the pandemic, and again, that was as a result of the pandemic, and particularly around the restricted visiting. But stuff that we did do that really benefited the patients was we provided free newspapers and magazines to inpatients who wanted them, and we funded that through our COVID money, because obviously we're very conscious, you know, that with visitors not coming in, being able to get those items. So we had a service that went round and did that for them, and that was free, and that was very well received. We did pipe Bluetooth music into paediatrics, and again, that's something we were going to roll out across the organisation. Again, that's been well received. We introduced the announcement bits. Obviously, you'll hear all the announcement, new technology that's within the organisation. I mean, during last year, really, it's only particularly the staff that have benefited from that, but it's been really useful in reiterating our messages that we needed to get through to the staff. Again, a lot of it around IPC, clearly, precautions and COVID. And all of us, myself and Suzanne and David, have all done voiceovers for that. It's a bit disconcerting when you're walking down the corridor and you suddenly hear your own voice coming out with an announcement, but it's gone down well. We've had really good feedback from staff around, and it plays music as well when an announcement isn't on. The other bit I've mentioned is medical examiners. Oh my goodness, that their addition has been absolutely fantastic to the bereavement team, and that those teams are working so much closely together. That again, we've had some fabulous feedback from relatives who are bereaved and around that service and how it really has improved. So I think again, just to do a shout out to the medical examiners and the impact that they've had. And then the other bit I'll just mention is around the healing arts, and we have paused it. Because of the waves of COVID, but we're reinvigorating all of that now. And we really do want to make ED an exemplar around the healing arts. So I've got a visit over to Chelsea and Westminster. They're seen as they've done this really well. So I'm very excited about seeing that. Brighton and not Brighton, Bristol is another trust who've done it really well. So I want to see it for what it is really, and I think then we can bring some really good practice back to the ED. And Marcine, our non-exec director, who's got a very keen interest in this and a lead, is very keen for me and her to do basically a walk of both sides of the trust from one end to the other and just look at where the opportunities are to really improve the healing arts bit, and then bringing our local expertise into that and improving our space around it. So we're really keen to get traction on that. So it's been a mixed bag really from a patient experience, but our Viewpoint, we launched back in October our new patient feedback mechanism, and again, because of the situation with COVID, it was a bit tricky, but actually, again, going forward, so the results, the yield on that feedback isn't great, but we are getting traction with that, and the introduction with the text messaging now for both inpatients and outpatients has really helped. And it's a key focus for us to get that feedback percentage better. I'll leave it at that, and Andy, and take any questions if anyone's had it.
Thank you. I think Chris, you've got a question.
Well, it's not a question actually. It's just that it's supporting Andrew in terms of the progress that's being made here, and I think Charlotte's and her new team are doing a really good job. I think one of the things I really noticed and I'm really pleased about is the broader context now that we're seeing the patient experience. So the healing arts and everything that's happening around that, I think it's great, because it's traditionally been around complaints, which is obviously important, but not everything around the experience, and it's always the afterglow, isn't it? So that's what happens afterwards. So I think we're doing some really positive stuff now, and I think the report is starting to bring that out. Just wanted to make reference also to the real-time patient feedback of around 6%. We did discuss this in quality, because I guess the national average, the national target is around 20. So what is it we can learn from others to raise that, I suppose, is one of the challenges that we've got to get ahead of ourselves. But I think, just reflecting, looking back in a very difficult year, I think the team are really now making some great progress on what has been an incredibly difficult year.
Thank you, Chris. And just a quick comment on the feedback one, because a few weeks ago my daughter was in for a minor procedure, and I guided her to Viewpoint on the way out, I should say, and stood over while she did it. And I would say that given people's attention span today, it's too long. So it's very easy to do, but it goes on and on and on. And I would just say, have a look at that, because attention span is everything. And if people start giving up halfway through, and I can definitely say she would have if I hadn't have been there. So I think maybe have a look at that, because, it goes on from one screen to another. And yourself, don't you, from these surveys you get over the internet, if there's anything more than a couple of minutes, you bin it, or I do anyway. So that's the thought. The other thing I thought on compliments, I'd just like the board to be aware, those of you who are not on Twitter, of a compliment we got yesterday, because it's so fabulous. And this is obviously it's open, so on Twitter, a lady called Frankie, who said the staff at Ashford St Peters are the most incredible people I've ever met. Our mother died this morning from terminal cancer, and she was treated like a queen. Thank you for making the most distressing time for my mother, sister and I bearable. And then she goes on to say there was a lovely receptionist who escorted me to my mum in A&E, and David in A&E was wonderful, as was everyone we came across. She passed in Hollywood, and they couldn't have been more kind and caring. And I thought for somebody, I mean, I replied to her because I thought for somebody who's just lost their mum to actually go onto Twitter and do that was incredible. Actually, what a thing to do. And that's obviously been going to be passed to the staff. But you know, we get loads of complaints, but actually we do. I think there's a theme here from earlier, isn't there? We do a lot of things right as well, and sometimes we focus only on the things we get wrong, and actually we do a lot of things right.
Yeah, great. And just to add, Andy, I think, you know, Charlotte Broughton now is the head of patient experience, and Leslie, her deputy, are a fantastic team, and they only really came together in the new year. So I think, you know, I'm excited about, you know, with their leadership actually, and the you know, the ideas and thoughts they've got for taking our patient experience forward is great. So watch this space.
Great. Anything else for this report? I think it's really moving on this the patient experience. That team is very, very good. Okay, so we come to the health and safety report now, which of course the first thing it says is we haven't had any fires, and immediately we get a couple of fires. So, you know, almost inevitable. But Tom, are you going to lead us through this?
Yeah, thanks, Andy. I was gonna mention that. Clearly, we have had a couple of fires actually, because on the day that we were all responding to the Ashford fire, then a number of us later on were evacuated onto the front entrance at St Peter's to see another fire appliance make its way, but fortunately no harm done there. So, but no fires reported in this report. I'll take the report as read. Clearly, it's been presented already by Chris Bell, Director of Estates and Facilities, to Quality of Care Committee. I guess the main points coming out of it. So this covers October last year to June this year. There are 6 reportable incidents, RIDDOR incidents, which is kind of in line with the trend, a little bit lower than previous reports. Within that, there are no COVID-related reportable incidents, although sadly, as we're aware, 2 of our staff did die in the period of COVID, both of which are being investigated under the normal process, but no clear link between workplace incident that would require us to report those under RIDDOR. Violence and aggression remains kind of consistent. The report references the introduction of the stab-proof vest that we're currently we're piloting and monitoring. What we have seen an increase in over the period is slip, trips and falls, and in fact quite a big increase. And one of the culprits seems to be the bus stop at St Peter's, the location of that and the steep slope that leads up to it, and the desire of people to kind of shortcut that piece there a little bit and go across the grass. So we've fenced that area off now, and unfortunately we haven't seen any falls since. So it looks like that might be potentially the solution for that one. And then finally, just to mention training. So in relation to health and safety training, mandatory training, we're at 92%. Fire training, we're a bit behind where we want to be. Our target is 90%. We're at 82%, which isn't too bad, but we've got a little bit of a way to go to hit our target there. But happy to take any questions or comments.
Thank you, Tom. Any questions for Tom on this one? Just on the violence and aggression side, I mean, I think we piloted the cameras, didn't we, some time ago in A&E and with security staff. Have we had any indication that has been successful in lowering tension? Because that was the thing, isn't it? Mm-hmm. Have we got any feedback on that?
Andrew might want to comment on that. I mean, I think the feedback I get is that it's a really good way of de-escalating. You know, because just visibly seeing the camera and the process of saying I'm going to turn the camera on is in itself a way of de-escalating the tensions that there might be. So I think there has been an impact, and certainly the porters and security guards feel safer wearing them. I don't know whether Andrea or other wanted to comment on that.
Louise, I think you had a comment.
Yeah, I was just going to say, I mean, we talk about it as being a pilot, but we've now established it as a way of working for those teams. Yeah. and we do regularly look at the data. One of the themes under the Workforce Transformation Programme is around safe environment, and this aspect we look at as part of the data set around use of the camera and any learning that we've got from incidents. But as Thomas said, it has been universally successful in all of the areas that we've used it in, and we're now just thinking about other opportunities where we could deploy it. I'm trying to make sure that we're not deploying it as a way of trying to resolve a system issue. So there are some examples whereby we're starting to see some issues in terms of patient complaints and patient behaviour, but I would say that's associated more with the system that they're trying to operate, and therefore we need to resolve the system issues rather than bringing in mitigation in to support the staff. But notwithstanding that, it's certainly been a really good methodology for de-escalating incidents and, where necessary, recording incidents.
Okay, thanks, Louise. Andrea?
Yeah, just to reiterate, I mean, the feedback I've got actually where this has really gone down well, particularly with the nursing staff, is ED, where they do tend to get, you know, unfortunately, a fair share of patients who are aggressive, or even relatives actually that may be accompanying them. We haven't seen so much of that in COVID, but certainly that is a risk, and they felt that it has completely de-escalated the situation, and they feel, yeah, more supported and safer with that. So just to give that feedback, it's been good.
I suppose the scary thing is that without those cameras, the figures would be much higher. I think, particularly, you know, distressing to see that, you know, a couple of knives have been pulled as well. And I'm presuming those will just go through police prosecution rules now, and that we're backing staff up in that regard. Yeah. Okay. Right. There are no more on that. We'll move on. Thank you. And we've now got, oh, right. We've seen the Guardian of Safe Working report, David. I know this has been to Quality Committee as well.
Yeah, so this is so it's been to the Quality of Care Committee. This is the distillation of the 4 quarterly reports. I suppose there's a few things just to pull out on this. I mean, one thing is just to recognise that this has happened through an incredible time for the juniors in terms of altering their rotas, flexibility, doing different things. So I think it's worthwhile just considering that when you look through the report. But actually, you know, it does demonstrate that the systems in place are working very well now. I think that one of the things that is very interesting is the number of rota gaps that are now being reported is the lowest it's been since 2016. And I think that is by a huge amount of work that Louise's team has been doing in terms of identifying when there are gaps and filling those with bank and agencies and those mechanisms, and also other fantastic pieces of work that have been done with within the medical workforce, such as Ashford and the MAC team and the Remedium team, getting doctors in and getting them inculcated into the organisation and looked after, and that I think's made a tremendous difference. And I think also the Rob Menzies and his team in negotiating changing rota shifts has also made a great impact. So I think overall it's a reassuring report. I think there's an enormous amount of detail in it, but it does show that this system, I think, has had a lot of merit and is now functioning very well, and it is a good link with all the right people in understanding the work pressures people are on the rotas when they're not when there isn't the capacity to do the work they're asked. So happy to take some questions, but it's quite a good read.
Jane, did the Quality Committee have any observations on this?
I think for us it was good to see the quarterly reports go to the People's Committee, so we needed to receive for assurance that this had been our responsibility under this had been discharged. And I think for us, we were pleased that none of the exception reports related to direct patient safety issues, which I think is really important for us at the Quality Committee. So just to make sure that is recorded.
Yeah. And I think that's a really important point, Jane, because that's where we did quite a lot of work in understanding if something was reported as a safety, that it was properly investigated and looked at to see whether it was a patient safety incident or not. So that's a good point, Jane.
And it also went to People Committee, didn't it? This one.
It did. It came to People Committee last week, and we approved it, and we were assured, as you say, David, about the reduction in junior doctor exceptional reporting and the on-field rota gaps being the lowest it's been in 5 years. Yeah.
Okay, thank you. Right, anybody any questions then on this particular report? On the right trend, definitely, considering what has been happening over the past 18 months, it's on the right trend, isn't it? Okay, in which case we'll draw that quality and safety section to a close, and we'll move on to the performance section. So before we give Anne her spotlight, Merrick, anything to report from Modern Healthcare on the performance report?
Just turning got my microphone back on. I was actually thinking about covering in Modern Health, but in essence, a lot of focus within Modern Health on the performance report and probing really two aspects. One, is everything being done to now bring back all of the long COVID working and meet the aspirations of reducing the waiting lists, and as part of that, also making sure that we have the resources that we need in place to do it, and acknowledging, as we've already covered, the level of spend that's driving into the business. But I'll talk perhaps a little more on that in Modern Health.
Okay, thank you. So, Anne, would you like? You can take the report as read, but what do you want to draw our attention to?
Thank you. So, yeah, I realise that you're familiar from Modern Healthcare and Quality and Safety Committee with the contents of some of the report. And obviously, it's about articulating the assurance around the care we provide our patients and the access standards. I think there's 3 key points I want to make, please. One, firstly, probably the obvious one is, although we had a low number of COVID patients in the hospital in June, we still are managing our IPC, and all our COVID restrictions are in place to keep our patients safe. But that also has an impact on our operational flexibility. It's probably quite obvious, but I just wanted to get that in there. In terms of June, it was an exceptionally busy month. It was a busy month for all our pathways in, through and out of the hospital. Cancer was busy, diagnostics was busy, and we alluded to a little bit about the recovery. That certainly ramped up considerably in June. But the one that was the busiest and the overwhelming pressure in the hospital was from the front door and the urgent care standard and the urgent care pathways into the hospital. Those pressures were around mental health. There was an increase in ambulance attendances of 19%. There was a general increase to the front door of 18%. And June was busy in comparison to June of 2019, which was pre-COVID, but it was busy in comparison to any winter months that we had in the organisation. I think James made that point at one of the subcommittees, but it's important to labour that point. My third point really is around the recovery plan and the recovery progress. We have the performance against that has been reported. We are doing a lot to manage those backlogs, provide care to our patients on elective care pathways, and get back to the numbers that we all recognise. And we've made very good progress from the numbers that are reported in the report that you can see here. However, in the last few days, we have been reporting against a metric that we have been using since the end of the last wave in phase 2. That metric, it turns out, has changed a bit in phase 3, which we're now in the recovery period. No one is entirely clear what it's changed to. We've been in discussions with the ICS, who are in discussions with the national team. They're an example of 16 different reporting metrics that we've been given. So we are working through with colleagues in the ICS to understand which is the correct reporting framework, and we'll keep everybody informed about that as it materializes. However, just in terms of the assurance, it doesn't detract from all of the actions that are being taken both at the Ashford site and at the St. Peter's site with colleagues in the private sector and outsourcing and insourcing in order to restore those standards of care. That's all I wanted to say. Open to questions.
Thank you, Anne. Just to be clear on the thing that's changed, and I did ask for the change report to be withdrawn because I didn't want to confuse people at the last minute, to be honest, and better to do it verbally. Is it that every kind of hospital in the ICS is doing something different, or is the ICS quite aligned and it's difference between ICS and region? Where is it landing?
I don't think it has landed exactly yet. So we have all been reporting the metrics that we use to post phase 3 recovery. And James had conversations with his colleagues in the other acutes, and there is a lack of clarity there. The system have actually withdrawn some of the reports recently, or they've not reported recently because of this lack of clarity, and are in dialogue with the national team.
Okay, so, and does this all come down to money in the end then? Is it the measure in order to release the money?
Yeah, so historically we've reported against activity and we've reported against performance. This time round we're reporting against money, and money is measured by a SUS submission. So there's a suggestion that that's one of the metrics, or that is the metric that we will be using. But as I say, it's not clear yet. I'm sorry about the lack of clarity. As soon as we have it, we'll share it.
Yes, indeed. And obviously if that can come back up through modern healthcare as well, so that we can understand it. Suzanne?
So support Anne there. So the actual number she's talking about is the one that's reported against the bullet described national phase 4 recovery. And it speaks to a performance of 106% pre-COVID and 108%. And that's the number that we're saying it's a perfectly accurate number, but it may not be the number that's required for this measure. And as far as I'm able to discern, the guidance around it seems to be different at organisational, system, regional and national level. But
lovely.
But in many ways, as Anne describes, it's not an indicator of a failure to deliver our recovery in terms of activity. It's a financial measure so that we can be rewarded in accordance with the ever-changing agreement to reward our elective recovery. So it's a changing measure against a changing requirement. It's as clear as that.
And they only changed the requirement last week, didn't they, or something that's to reduce their financial liability. Yeah. Okay. Thank you for that. Any questions for Anne on the content of the report? And what I think I did say in modern healthcare, what was unusual this time is because we normally meet at least 5 of the 7 cancer standards. I think 5 or 6 or sometimes 7, and that's gone down particularly. Do you think that there's anything behind that, or is this just a kind of one-off month?
Okay, so cancer is a little bit different. So if I take you, it's page 12 of the 18-page report with the cancer standards. So the cancer standard for June is going to be reported next week. This report gives you a snapshot of where we are at the time of writing the report. The most recent closed activity figure for cancer is the May performance, which was reported on the 6th of July. And the reason that cancer lags 2 months behind is because it's a 62-day standard.
Of course.
Yeah, so it is slightly different. What we try to do in all of the reports is just give the board or the meeting the most up-to-date version of where we currently are. But indeed, the July picture is still being validated, and we won't upload it until next week. I think it's the 4th of August, but I need to check that.
And what's it looking like at the moment, Anne?
So the 2-week performance is looks like we won't deliver that, which is not something that we're used to, and that's down to volume more than anything else. And the 62-day standard is just a little bit off. It's about 2% off the standard. So that will really depend on validations. We're still waiting to understand about some of the biopsies, whether patient was positive treatment or not. Okay. There's a lot of technical validation that goes on behind that.
Yeah, I understand. Jane, and then Suzanne.
Thank you, Anne. James presented a quality-focused performance report at a quality committee, which has many of the metrics. One of the things we particularly focused on was the follow-ups and the challenge that we've got around that. And just, the disappointment that we're still, obviously, given the pressure in the system, we're still not really quite getting on top of the numbers as we've been used to in the past. It's just really that we had assurance that there is a clinical prioritisation around that. Yes. So it's just really for the board to be aware that we did have that discussion, and we were assured that there were clear processes around making sure that patients that were on the waiting lists were clinically validated, and I just really wanted that recorded, really, because it is worrying when you see the numbers, and certainly something that James highlights at each quality committee for us to be aware of.
Yeah, those are certainly numbers that we're absolutely not used to. We have established an outpatient clinical group to review the process and any likely harm. And we have a very, very clear process for that. It's actually shared across cancer pathways as well. So we're using a known process that the clinicians are all very familiar with.
Okay, thank you. Suzanne?
I only really just wanted to thank Anne and, in his absence, James and all the operational team, because they've had an absolutely extraordinary 6 weeks. I mean, David's nodding. He's been here a long time, and I've been here not as long, but a long time. It has been really challenging. And both James and Anne and all of the team and all of the clinical frontline have had to really, to generate this kind of performance is an extraordinary effort, and I'd just like to make sure that the board take this opportunity to thank Anne and James and the whole team and have that recorded, please.
Thank you. I'll pass on your thanks to the team.
Yes, here. Let's record that as a board vote of thanks. Okay, and I think that's fine. All done. Can't see any other questions. So thank you for that. So we're going to move on. Merrick, Modern Healthcare minutes, and then on to your Modern Healthcare annual report. We've still got Merrick.
Sorry.
There you go. All right.
Right, I'll just say that again. I'll do both at the same time because it's really relevant to do so. Look, as we've already touched on the early part of the performance report, modern health in really the last 6 months has substantially focused on operations and performance, not to the exclusion of all else, but really that has been very much the primary focus. And as I've already touched on, it's about ensuring that the delivery, both within the COVID context and then post-COVID catch-up context, has been optimized by the team. And as Suzanne has rightly said, I mean, they have been doing a stunning job in difficult circumstances. As much as possible, we also, in tandem with quality, look to focus on ensuring that standards, we aren't seeing any signs of standards dropping given the constraints that people are operating under, and we focus on that. Obviously, and this comes on to the second point, really, the finances that's within the committee, all of that has been not without cost, and the cost has clearly come in two forms. Additional staffing, both our own staff and bank and so forth, additional external agency staff, and of course insourcing, which is another way of dealing with the staffing constraints. And then the other aspect in terms of hardware that we brought to bear, and you'll see that particularly in the annual review. I can't think of a time really where we've had such a volume of additional and substantive resource brought into the hospital. We've had the various, I'll use the word pop-up, actually it's easier, theatres added in. And in any one year, doing one or two of those items would be a major undertaking of planning, not only bringing the equipment, finding the equipment, bringing it in, but of course, getting it staffed and integrating those new facilities in terms of the operational processes. And I think it has been really a staggering amount of work. But coming back to the finances, we are running, as we mentioned earlier in this meeting and in the closed meeting, we are running at a cost level considerably above our base level envelope that we've had in the past. And as we look forward, some of the concerns that we will be looking at within modern health is within the ever-changing envelope that we've been given, both in terms of performance envelope and financial envelope. What are we going to do as we get to some, frankly, impossible asks in the context of trying to meet the volume that we have at the right safety levels? We don't have any answers to the moment, but we know that the executive are extremely focused on this. And I think as we look forward, we're going to be talking about this more in modern health and how we deal with some of these very difficult balancing acts. Specifically, I want to talk about a couple of elements. One is the endoscopy, where we brought in extra theatres and then we dropped one out. Clearly, various concerns arise on that. To deal with those concerns, a special workshop was held for the executive and non-executive to look into the detail. A very impressive workshop indeed, and we took substantive assurance that the right decisions were made at each point in time as the facts evolved. I won't go into details, those will be covered in the minutes of those meetings, but we did take substantive assurance to those very difficult and challenging decisions that were taken. And then finally, I want to talk about capital. Two elements of capital. One, we are still working our way through the additional spend driven primarily from additional technical requirements after the PAU was commissioned. And in fact, as part of digging into that, we are going to, Marcy, myself and Chris, our new NED colleague, who will be joining Modern Health, we're going to do a little bit more work digging into understand, so make sure we understand the drivers of the additional spend, and we'll report back on a later point. Final point on capital is, of course, the capital envelope is constrained. We have cash, significant for capital, partly through land sale, partly through the extra bid that we made earlier in the year and successfully got it. But we have capital, cash available significantly in advance of the constraint envelope that we've been currently asked to work with. That is going to have operational implications for the hospital, and we have not given up the debates and fights to try and get a change to that envelope. And of course, circulated earlier this month was a letter from our local MP to make that point. Those are the key points I want to bring out in Modern Health. Happy to take any questions.
Thanks, Marek. Very clear on your report. Any questions from? Committee running well from my observation. So thank you all those committee members for your dedication to that committee. Really important one. And then we come across to the next one, which is people. So Dami, stage is yours for your annual report or any comments you've got on the minute.
Oh, thank you, Andy. So the minutes for the May meeting were approved as accurate at the meeting last week. Obviously, the conversation has moved on quite a lot since then and has been discussed in Suzanne's report, but all throughout this meeting, there is a recognition of the immense and sustained pressure that Team ASPH is under whilst trying to deliver this elective recovery agenda alongside maintaining business as usual in the face of a rising demand. And then there is winter and the possible RSV surge coming up. And this pressure, of course, places such a significant strain on the resilience of already quite exhausted workforce, with little room for stretch. As has been discussed earlier, obviously the metrics have changed now from what's in the minutes for May. We've got concerns with rising sickness absence. We've got increased complaints from patients about attitude and communication. We've also got some rising interpersonal kind of employee relationship issues due to rattiness and just reduced tolerance. But we were assured as a committee that action plans are in place to address these. At the last meeting, we also agreed that we consider adding a new strategic risk, this impact that the failing resilience might have on the productivity of our staff, on their retention, and certainly on the safety and the quality of care that we're able to provide for our patients. So we're keeping a close eye on that. On to the committee's annual report for 2020 and 21. I'll assume that the report has been read and just highlight a few key activities from July 2020 to May 2021. So as a committee, we've sought assurances on 4 priority areas really affecting our workforce. And there's been a major focus on the recruitment, the retention, growing our own as a system-wide piece, the well-being of our staff and other COVID-related issues during what has been quite a challenging year for Team ASPH, but also for the whole of the NHS. The format of the meeting changed throughout the year towards more lean governance with shorter focus meetings, as you know. At some point, we had the divisional teams attend the meetings, but we had to stand that down during the peak waves in view of the pressures on the teams. We're assured that that as a committee, we have received assurances on issues such as staffing, a reasonable bank and agency use, safe working of our junior doctors, the appraisal and the revalidation of our staff, and a number of workforce transformation work streams, such as well-being, growing your own, and more recently, flexible working. And we're pleased also that action plans are underway for developing a trust-wide culture of inclusion and diversity, and with additional resources pending for a cultural diagnostic program and some facilitated work externally. That's it from me. If Louise wants to add any more.
Louise, anything to add?
I don't think so. I think that was a very comprehensive summary, so no, nothing to add.
Thanks. Okay, any questions for Dami on either the minutes or indeed on the annual report from the People Committee, which, as I say, very good summary. No, duly received those reports then. Thank you very much, Dami. And we're going to move on now to the risk management strategy. So, Suzanne, you're going to introduce this with Sal?
I can do, but truth be told, Sal's done all the work. So I don't do with her team. I mean, I think this is a follow-on from something that we've kicked off some time ago, where we first of all, published our strategy. Then we adjusted our sub-board committee governance in order to deliver that strategy. Then we completed the risk appetite and the BAF work, and now this is helping shape the next steps, which, if you remember, was our ambition to actually drive the use of a risk management approach very systemically across the organisation, and to join up the dots between the board's and view and the BAF, and actually the decisions any individual might make at any moment on the front line, because obviously we're not always there to kind of give that steer. And so we've been working hard to kind of, with the support of some key board members, describe the strategy. So I would commend it to you, and ask Sal to add any points of detail and answer any detailed questions.
Thanks, Suzanne. Sal?
Thanks, Suzanne. I think that really gives the context of why we're bringing a refreshed strategy following a mid-term review. The only thing that I would add is that we felt it was quite important to introduce some KPIs so that we could understand how successful we are being in improving our levels of risk maturity. And also to say that the refresh strategy has been fully approved. It's been through our Trust Executive Committee, and it's also been approved by Audit and Risk. And as you might imagine, Marcin was closely involved in ensuring that it accurately reflected where we are now and the remainder of our journey. And we would, of course, revisit it once we've refreshed our Together We Care strategy, just to make sure that it is completely supports and is aligned with that.
Okay, thank you, Sal. Any comments on this? So just one question on the committee oversight and monitoring. It's got reviewed rightly. It's got reviewed quarterly at Audit and Risk Committee and Trust Board subcommittees. But it doesn't actually say that it goes to board, which clearly the Audit and Risk Committee Act, is pulling it together, and then it comes. It should come here, not necessarily quarterly, but it's not clear about that.
Okay. I suspect that what we've done is we've said that the risks in their detailed format is considered by the Audit and Risk Committee in order for them to give assurance to the board that the actual individual risks are being managed. But I'm very happy to update it so that it's clearer that it is also seen for oversight at each board.
I mean, I think it's really clear. It's a really clear strategy. That was the only point that kind of
okay,
struck me.
thank you, Andy. Yeah.
And interestingly, there was a risk. Suzanne, I think you were on it as well in the system risk meeting yesterday, where you could see Marcin's fingerprints all over some of the risk appetite work, which is very good actually. And she was given credit right at the beginning of the meeting by Peter Collis for the work she'd done with the team. So in a way, our approach is actually starting to be adopted across the system, I think, in many ways, which is very good.
Good to hear.
Any questions on what's presented here? How's it gone down with the divisions, Sal? How do you think it's going to bed in?
They are already quite far along the journey around this, and I'm sure Suzanne would want to comment that the conversations that we're having at the Risk Scrutiny Committee and at Tech are really starting to mature in the level of challenge and response, if you like. And of course, I have to mention Abby, who's now on maternity leave, but as our corporate risk manager, that post has been really important in moving the agenda forward, just supporting the whole agenda. But Suzanne might want to add.
Yeah, I can see David's put his hand up. So I know David chaired the last Risk Scrutiny Committee, so probably useful for him to share his observations on that.
Yeah, David?
Well, I think I was just going to support you, Sal, actually. I think it just feels so different now, the discussion you have. Rather than people defending their risk register, you have a proper debate about it. And I think it's been a real sea change. And I agree with you. I think you and Abby have done an amazing job on that. I mean, Abby's with the teams all the time, talking to them and trying to organise in a way. And when we're not all the way there yet, but it seems to be a more collaborative approach and an understanding that we can't just leave a catastrophic risk on the risk register. We've got to work out how we're going to manage that risk and mitigate it and get rid of it. And that's, I think, a massive change. So, I mean, I agree with you, Suzanne. We've got to thank Sal and Abby for doing an amazing piece of work here.
Great. I'm really pleased to see how far it's come. Actually, I think it really is very, very good. Okay, so there's no other comments on that. Thank you very much for that, Sal, bringing that through. We now move on. Chris, anything you want to bring our attention to on the open minute or digital?
Well, I was just going to say, actually, in terms of this particular committee, we had a lot of attention on the risk, and Marcin was again very helpful in actually helping us scrutinise that, because this is quite a complex and far-reaching agenda in terms of digital, and as an enabler of everything in the hospital, it's going to become increasingly more so, I think, in the future. So we were talking first of all, of course, around EPR. Surrey Safe Care, and Suzanne, I think, has covered that very well in her report. Also around our maintenance of our critical systems, and then cybersecurity. So it's quite diverse in terms of how sort of like risk has impacts on us. I just wanted to pull out the Surrey Safe Care, just to say that is still on amber. It is a massive project being undertaken on top of everything that's been happening in terms of restoration and recovery and COVID. It's just quite remarkable. But I guess we are at a sort of testing stage, a critical stage. We have had it's not been plain sailing at all. And as Suzanne sort of has illustrated, the training now involved in the transfer of all of this in terms of building new systems for both hospitals is quite enormous. And that's going to be the focus of attention over the next few months. And I think enough has probably been said on that. There was a deferral of what we call the TL3 gate, but that's going to be made up, Simon believes, in terms of prep before we go into dress rehearsals, in terms of when the transition is made, which, it's going to be around December for both trusts now. It's just a go live together. I just wanted to also tease out we've got a digital program steering group now. We have Nikki Raymond, who's joined us from Cornwall. She's doing some really, really good work to support Laura now in terms of trying to get some sort of change program and discipline around the process of how we make changes through digital. Of course, there are more and more requirements coming through from everyone, and we want to try and get some sort of order around that. And so we went through a TOR and further discussed that at the latest one in July. Also, Catherine gave us an update in terms of what's happening around Surrey, in terms of Surrey Heartlands ICS. And I'm really pleased actually now there's some really good sort of complementary activity be going around in terms of Surrey Care Record, in terms around digital inclusion. And I think the whole of COVID has highlighted the health inequalities around the system. And I think there's a lot of good work going around that area now in terms of how that's supporting population health in those areas. And we've already discussed, of course, PACS today, which we're really delighted that's gone through, and that we have got a good quality solution. I remain to be dismayed why Frimley don't participate. We mentioned that at the beginning, but they don't. That's really it in terms of the key areas that we covered. So any questions, please fire away.
Thanks, Chris. Any questions for Chris on that? I think I had a conversation around Surrey Safe Care with Sue Shuver last night, Chris, and she was asking me what I thought, where I thought we were, and I said, we're in the trenches, we're in the muck and the bullets, and that's where we'll be, and there'll be, it will go, it will not all go smoothly. That's the nature of the beast, but I think we'll. I said I still have confidence that we will get there with a minimum viable product in the timescale.
Yes, and there was discussion obviously around this minimum viable product, and what that means, of course, is the bare minimum you can go out with. This is a gradual thing. It's not. It's although we're all starting together. I think the board's got to understand that this is going to be the start of a massive transition for us. And it won't go smoothly, and we have to be aware that it is going to be in the trenches, and that there's remarkable work going around in all quarters to try and to keep it afloat. But at the moment, although it's an amber, we are moving in the right direction, and I think that's a positive thing.
Great, thank you. Anything else for Chris? No, good. So we'll move on to the regulatory section now, and Merrick, you're the last one standing. Keith has left. Marcine's in the Mediterranean.
I see, yes. No, you're right. Well, yes, I am. But when Marcine comes back, I think we can expect quite a shake-up in that space. So we're looking forward to that. So just to talk again, I'll talk about both the minutes and the annual review. Actually, there's really little to say on the annual review, so mainly want to talk about the minutes. And just really 2 points here. The first one, it's covered in the minutes, but just this bizarre thing where we build a new building or new car park, PAU, whatever it might be, and immediately have to impair it, i.e. it cost X, and we say it's worth less than X. It's just a bizarre artifact of the way the NHS accounts for things. And it's certainly nothing to worry about. It's not like we built something that wasn't right. It is just a bizarre accounting artifact. So the other thing I want to just talk about is the year-end audit opinion. We are heading, and rightly so, for a clean audit opinion with one caveat. And that caveat is really going to lead me on to my second point, which is we find ourselves in a strange situation again with Mazars, that last year we had an issue to do with the fact that they were unable to complete the stock count. And we found a way around that last year, but it wasn't without its challenges on working with Mazars on that, but we found a solution. And this year we find ourselves in a different but related situation where Mazars have not been able to do their value for money audit work, and they're going to delay that to after their audit opinion, and therefore the audit opinion will basically say they've not been able to do value for money, and we knock it into the following year. There was guidance issued very late centrally to the effect that if auditors were up against it, they could delay their value for money audit. At the moment, and we're waiting to see this in the September meeting, Mazars' approach was to leave it to imply by absence of any other statement that it was because the hospital were unable to provide them the paperwork and support to do their audit. That isn't the case. And in fact, we found, as covered in the minutes, that Mazars have said to us that they found themselves in an extraordinary position of staff motivation and lack of staff across their whole firm, which has led into a resourcing issue that's affected us, as I've articulated. We've accepted that for what it is. It's interesting that we haven't heard that with the Big Four, not seen that in the press. So we will be looking, and I'm here jumping ahead speaking for where Marcin may view this, but we will be looking for some assurances from Mazars in terms of next year's audit and their ability to resource matters adequately. That's probably all I really wanted to say on audit and risk committee, but happy to take questions.
No, thank you, Merrick. I think we've all got our eye obviously on Mazars and doing this final piece. Did the audit committee get a sense that they would be able to do it by then at least?
Well, actually, I mean, I raised in the audit committee the point, and again it's in the minutes, that what is value for money in the context of what we've been through with COVID? All of our metrics that we've seen in the operational reports, have kind of been severely damaged, shall we say, by what we've gone through. But we didn't really conclude that anything other than it was possible to do it. People felt it could be done, and Simon was keen for it to be done. So we've got a meeting that we've set up in September, early September, to look at the final audit opinion, and that will be another great opportunity for us to ask exactly that question, Andy.
Okay.
Are you assured you're going to get it done?
Yes, indeed.
But I don't want them to do a bad job in it and find out we've got some strange opinion coming out that is driven by their resource rather than our performance.
Exactly. Yeah. Okay. Well, thanks to the audit committee for being on this one. I know you have been on it, and we've got to work through it now. So thank you for that. Okay, I'll move on from the audit then. So we've got another self-certification for NHSI. Who's down to do this? Oh, it's you, Suzanne. Not normally you.
I think it's normally me that says, this is the standard notification. Here's the documentation. Are you approving it? And then Sal answers any detailed questions. Fundamentally.
I mean, this is a very straightforward one, isn't it?
It is.
Report.
It is. Yeah.
Sal, is there anything you want to add?
No, it should look familiar to most of us as the second part of an annual requirement, and the caveat is that we may be asked to provide evidence of what we've actually said. So it's just for approval.
I've got one thing on it, but Jane, you've got your hand up.
Yes, it is something we briefly talked about in our pre-meet. It's just on page 7, Sal, for accuracy. It says the board is actively engaged in the quality of care. Okay, have you got that bit?
Sorry, which point?
It's page 7.
Yes.
Page 7, mitigating actions.
Yes.
Okay, and then the
yes, I can see it. Yes.
Yeah, the paragraph starts there. It says the Quality of Care Committee is chaired by a NED with attendance from 3 others. In the terms of reference now and in the arrangements that the chairman has made, we only have myself and 2 NEDs.
Yes.
So just for accuracy, really.
Apologies. Yeah, I'll update that. Thank you,
Great,
Jane.
then that'll be in terms of reference. Okay, thanks.
Of course.
Yeah, and I think the other one I had, Sal, was I don't think we have monthly Modern Healthcare Committee. I think we have 9 a year. I know
so
we often.
That clear. Yeah.
Yeah, you're right.
And we say leadership and board walkabouts both undertaken, albeit these have been affected. I'd have almost said severely limited by.
Severely limited. Yeah.
Because that's true. Yeah. And that otherwise.
Okay, I'll change those 3 things. Thank you.
Sorry, did somebody say something?
Yeah, Andy, sorry. I just looked again. Sal, in the same place, it says the Quality Governance Committee. I'm not sure that there's the Quality and Safety Committee that reports into us. That just needs to change for accuracy as well.
Anyway, I get some value add from bringing it to board today.
There you go.
Thank
Good
you.
job.
Thank you all.
Just to say we've read it. Okay, thank you for that, Sal. And do we have to approve that? It says receive in the agenda, but it's approve, isn't it?
Yeah, we have to approve it.
So we'll approve it subject to those few minor changes.
Yeah.
Okay, yeah, everybody happy with that? Okay, the trust seal fund's not here, but I think we can take it as read. Anybody got any comments on the trust seal? I imagine the lease treatment rooms in Woking Leisure Centre are for the physio, are they? Yeah, is that right, Tom?
Yeah, and I think we put some midwives in there as well, if I'm not mistaken.
Well, you've got to put them somewhere.
Yeah.
Yeah, so midwives and physio, yeah, that's fine. And construction of the new modular wards, of course. All right, so I think we can receive that. That's fine. Which leads us to the rather long NHSI oversight framework. I think, was this for consultation document or is this the final document, Suzanne?
I think this is the final proposal. There was consultation.
Tom?
Yes, I can verify that. There was a consultation and we responded actually to the consultation, right. and this paper is about the final document.
Okay. Suzanne, do you want to?
Well, I mean, I think the paper's quite straightforward, really. I mean, as ever, the national regulator requires a way of categorising us as an organisation and as a system. The adjustment here is really aiming to move more to a system view, so it's in support of the legislative changes we briefed earlier. And you can see within it suggestions around how to review organisational and system performance, and give an idea around the kinds of intervention and the way that would be characterised within each of the segment descriptions. So, for example, earlier in the meeting, Merrick was referring to sort of being in special measures. Well, that won't exist. You'd be, I think it's a segment 4 organisation in this example. And then there's a sort of clearly there'll be a sort of a I don't know, it'd be like, what's that hat called in Harry Potter? There'll be some sorting hat. There'll be some sort of sorting hat methodology to make the initial judgments on which category we're in. And as you can see, that's described as, the default segment is category 2. But I'm yet to be formally advised of what our segmentation will be. And I suppose what's positive around it is that the intention is to move. So it talks about support from the national regulator where it's necessary. So support is always welcome. And then the appendix gives you the kind of metrics and where they'd be applied. And I think Paul Doyle did a good job of sort of trying to demonstrate where we'd be on those. But I guess it'll be a conversation and a judgment between the Claire Fuller and her team and the regional team about where we'll land. I would say we'll be a segment 1 organisation. That's what I'm going to advise them. Comes out the sorting hat for us.
Yeah, her view at the moment is that to put us all in 2, I mean all the organisations, so that she doesn't have any embarrassment of somebody going to 1 and then being demoted. So I'll leave you to have that conversation.
I have open negotiations. I think she should go for it and have the celebration and the feather in her cap for having at least one organisation on her patch, possibly more in segment 1. But
Yeah,
possibly I'm biased.
And you're right. SOF4 is the naughty step, basically.
Yeah.
Yeah.
But happy to take any questions. I should thank Paul Doyle, who did all the hard and heavy lifting on this paper. So he's not here, but thank you, Paul.
No, it's very good actually. But it's basically NHSDI sorting out what the ICS is going to do and what they're going to do and how they're going to work together, hopefully, rather than separately.
Yeah. And that's a good thing, and to be welcome. So we'll work with them and support the development.
So this is just for receiving. Has anybody got any questions about it? And if you put that together with what we had earlier, the update earlier on where we are with legislation, etc. You can see that things are moving, and they're moving quite quickly now. Okay, thank you, Suzanne. I think that's fine. Anybody got any other business? No. Liz, have we had any questions from the public?
No, we haven't. Not this month.
Well, that's a first.
I think it is.
Don't think we've ever. Right. Okay. So no questions from the public. All right.
Sorry, Andy, I've got my hand up.
Oh, sorry.
Sorry, I'm a bit late. It was just to give you some feedback. If you remember in the previous open board, we had Raoul, our catering manager, come to talk about the transformation that they've made to catering services. Yeah. And he did that with William before William left the organisation. Well, we nominated Raoul as part of a request from NHS Improvement to put forward any people that we thought were worthy recipients of an evening at 10 Downing Street. And he went. He was contacted. He thought it was a joke, so he ignored 3 emails. They obviously didn't tell me that they were going to be contacting him. And eventually, when he found out that it wasn't a joke, he turned up and he still thought somebody was pulling his leg until he was taken into Downing Street. He was one of only 20 people in the country that was at this evening.
Wow.
He said that he was alongside, obviously, doctors and nurses. He was the only ancillary member of staff. He obviously talked a lot about Ashford and St Peter's, raised our profile, talked about what a fantastic experience it had been. They're obviously very interested in the fact that he was previously on furlough and now in substantive employment, and the connection with our Grow Your Own strategy. So fantastic. So he had a great time. He keeps asking them, because they promised him some photos and then we can do a proper
that'd be great
on it, but I don't think he's received them yet. But I just wanted to do that as a follow-on from the staff story last time.
Great. Oh, thank you. That's really, really encouraging. So the prize we gave him for being so good is to have a night with Boris. That.
Hope Boris didn't poach him.
And then
he loved it. He had a great time.
That's good. No, it's really good. I mean, that's really good. The in the garden. Thank you for that. Okay. Oh, that's a good point. So I think today on reflection, I thought the patient story was fabulous. I don't know what other people thought. Very moving, really, and and very upset because we've actually been doing really well on organ donation, and pre-pandemic we were hitting well above our weight, really, on the numbers. And certainly Emma's got a great way of talking to people and getting alongside people, and getting people to commit. And she does it so sensitively as well. It's a real asset. I know she's not technically ours, but she's a real asset to us and any other trust she works with, really. Anybody else? Any reflections on today's meeting?
be interested to hear how Chris has experienced his first board meeting. But he may not want to say anything at this point.
I think he's dropped off. I don't see him.
Okay. Sorry, I've missed that.
He didn't come in for the second half, no.
He did extend his apologies that he'd been called away.
Ah, right. Okay. Well, I'll no doubt hear from him later. I shall feed it back. Okay, great. Well, it's 13:24, so we have 6 minutes of your life back. So thank you very much for all your attention. And Chris, hope you feel better soon. Thank you for coming, given you're not well. So, all right. Thanks very much, everybody.
Thank you, everybody. Good meeting. Thank you. Thank you, Andy.
Bye.
Bye.